Good morning.
I'm just waiting for the green light from Michelle.
Mr. President, we're ready to go live in 5, 4, 3, 2, 1.
Thank you. Good morning, everyone. Welcome back to the Montgomery County Council. First, let me just explain that unfortunately I'm working from home and masked up in order to follow our public health guidelines. Since we have some COVID cases in my family, we'll be fine, but I just wanted to explain that and not have it be a distraction. Second, I want to acknowledge the horrific events we witnessed last Wednesday on Capitol Hill that deeply affected not just our democracy, but many of our residents personally. I want to share the Council's deepest sympathies to the families of those who lost their lives, including Capitol Police Officers Brian Sicknick and Howard Liebengood. And I want to recognize the bravery and dedication of our Montgomery County police officers, as well as the Maryland State Police and the Maryland National Guard members who were called in to protect our legislators and the democratic process last week at our nation's capital. Finally, I want to thank and honor our members of Congress and their staff who continued the essential business of the people immediately following the insurrection. Can we begin with a moment of silence for those who tragically lost their lives during last week's attack on our democracy? Thank you. We'll begin with general business. Madam Clerk, do we have any announcements, agenda changes, or petitions?
Yes, good morning. We have an addendum, and under general business, correction under number 1, the public hearing on Bill 4620, Police School Resource Officers Prohibited, originally scheduled for 7:30 p.m. on January 12, 2020, has been postponed and will be held at 7:30 p.m. on February 4, 2021. The public hearing, correction number 11, the public hearing for the proposed amendments to the 10-year Comprehensive Water Supply and Sewage Systems Plan, 6 category change requests. The T&E Committee work session is tentatively scheduled for February 1, 2021. Number 14, the District Council session at 3:45, correction A, Introduction, Shady Grove Sector Plan, Minor Master Plan Amendment. The public hearing is scheduled for February 23rd, 2021 at 1:30 p.m. Also under announcements, the Council is seeking applicants to serve as the Council representative on the Board of Investment Trustees for the Montgomery County Employee Retirement Plans and the Board of Trustees for the Consolidated Retiree Health Benefits Trust. The deadline for applications is January 25th, 2021 at 5 p.m. Also, the public hearing on expedited Bill 5020, Landlord-Tenant Relations, Fire Safety Removal of Mercury Service Regulators has been rescheduled to January 26th, 2021 at 1:30 p.m. That is all, Council President.
Thank you so much, Madam Clerk. Now the Council will sit as the Board of Health, and we'll have an update on COVID-19 from Director Dr. Crowell and Drs. Bridgers and Stoddard.
Good morning, everyone. I'm here today to be part of this conversation in Dr. Gales' absence, but also will be joining you all more frequently, I hope, as the year goes forward, especially since you're going at an earlier time. I'm going to turn this over to Dr. Bridgers to walk you through where we are with the stats and on testing and on vaccination, and then talk a little bit about Q&A and next steps, and then open it up for you all for questions and for any other conversation we need to have. So, Dr. Bridgers, your show.
Good morning, everyone, and thank you for allowing me the opportunity to give you a public health update and Dr. Gale's much needed respite. Want to start with an overall update on community transmission with data I received as of yesterday. The state of Maryland had 309,686 cases. Cumulative cases of that, 3,012 were new cases. In our jurisdiction, as of yesterday, we had 460 cases with a 7-day positivity percentage of 7.1 and a 7-day case rate of 47.5. Needless to say, community transmission levels remain high, representing a post-holiday increase in cases. At the end of last week, 4 of the 6 hospitals were in the red zone regarding capacity, with 1 other in the yellow zone. We've had conversations with those hospitals, and we continue to monitor their ICU capacity daily. Additionally, the remaining hospitals, while not near capacity limits, have observed longer hospitalization periods, increased emergency department visits, and the periods of curative of illnesses for those COVID-19 patients have slightly increased. Again, we continue to monitor accordingly and will recommend necessary actions as needed to curb further transmission. One point to note, on Sunday, January the 10th, we saw the highest single day cases reported, which was 639 cases in Montgomery County, as well as the single highest 7-day average since mid-December, which was 474 cases. So we need folks to continue to be vigilant, wear your face covers, practice those physical/social distancing, and wash your hands as often as possible. Along those lines, in our testing efforts, we continued our widespread community testing network in partnership with numerous community agencies, including the exceptional efforts by the African American Health Partnership and LHI Salute Ebenestar Initiative. Our weekly totals last week were 12,244 tests across 25 spaces, including our employee testing initiative. I want to move now to much of the discussion around vaccine capacity. Just talk about some of the updates and bring folks where we were since we last met, or Dr. Gales gave an update prior to the holiday break. Pfizer and Moderna vaccines, EUAs, emergency use authorizations, have been granted successfully and have begun distribution. There are no pending candidates under the EUA consideration currently. There are other potential candidates entering different stages of clinical trials, including Johnson & Johnson and 1-dose vaccine by AstraZeneca that folks may have heard being administered in the United Kingdom. We received the Pfizer doses that were solely distributed to our hospitals and long-term care facilities beginning the week of December 14. All of the hospitals have received their allotments of doses that we are aware of, and we have been in contact with their chief executive officers to monitor any vaccine challenges that they have, or if they didn't receive any information, any vaccines and related information to help support their initiative that they have directly with the Maryland Department of Health. Long-term care facilities, including nursing homes, group homes, assisted living facilities, also receive their vaccines through the partnership with the retail pharmacies, including CVS and Walgreens. The Moderna vaccine, my apologies, were approved, and we received our first doses during the week of 12/21. Local health departments across the state received 100 doses as a base to test their distribution strategies. Those further allotments increased to a base dose of 500 doses. Consequently and subsequently to our initiative to receive more doses, our second allotment was 4,200, followed by 8,600 and 6,700 for this week. Keep in mind, we made those requests. Unfortunately, we did not for this week receive our request. That request was initially 12,000 doses. As a matter of fact, as of 9/39, as I present to council sitting as the Board of Health, we have not received that weekly allotment. These determinations are entirely made at the state level, and we're using multiple community sites that I will speak about later on in the presentation, and I have a brief PowerPoint to present to council. And we've had ongoing discussions with additional clinical partners to expand these locations. Currently, again, there's a rate limiting factor that prevents us to move progressively and aggressively through the initiatives, and I'll present that later on during this discussion. Moreover, each week the state asks reps for our immunization team for an estimate on the number of doses we would like. Each week we strive for the maximum amount. Again, we requested 12,000 doses this week and only received 6,700. Within that note, we received the highest doses across all of the 24 jurisdictions in Maryland for this week. Dr. Gayers shared with me just last night as we were strategizing regarding our prioritization and our allocations and the lack thereof, that he met with Deputy Secretary Chan to emphasize that we would like to have higher doses or the highest doses as possible regarding our program expansion efforts and our anticipated ramp, exploring partnerships with clinical providers. The state responded last week with their allotment of over 8,000 doses. However, when we requested the doses this week, it was cut. Dr. Gales is also following up and has asked for additional clarification as to why we didn't receive the allotted dose. We also sent letters to healthcare providers back in December on the 17th, and we started our survey to canvass their needs for not only their providers and their staff. We had a conversation with the Medical Society of Montgomery County yesterday, and we've asked the providers who participated in that discussion to request directly to Deputy Secretary of Health, Chan, to get access for the ImmuNet system that they themselves as a local provider can go into the system and obtain doses similarly to their ability to request flu vaccines. We've been following the CDC's and the Advisory Committee on Immunization Protocols and Maryland Department of Health prioritization matrix. We have a website with COVID vaccine, and we have those list of matrix, and I'll share those prioritizations and sub-tiering later on in the presentation. Given, again, the limiting constraints of having enough vaccines to progressively move through the prioritization categories and those sub-tier categories, we anticipate that we will still be vaccinating through phase 1 for the next 2 to 3 weeks. We continue to revise and finalize our plans based on guidance that we received from the Maryland Department of Health. Back in October, we sent the Maryland Department of Health the draft plan with our anticipation, the number of doses, target populations, and the prioritizations that were set forth at that time. It has since then changed somewhat in the prioritization setting since mid to late December, and we've altered our plans and revised our plans and evaluate our plans based on that ongoing change in guidance. Absent of having a larger federal guidance, we are left to determine and stage many of our vaccine clinics according to the vaccine doses that we have available. As of this week, and I will go into more of a detailed representation in the PowerPoint presentation of our overall vaccine totals, the amount that we receive, the status where we are in the county as far as our vaccination effort as compared to the other counties, and the clinics for this week. We have clinics scheduled today, this week at White Oak, at Germantown Recreation Center, our Public Safety Training Academy. Thank you for our fire and rescue who are supporting our efforts to vaccinate our public safety officers, our fire and rescue, our public safety officers at our county and municipal level, our detention center staff, our 911 dispatchers, and any other public safety officer in the county who doesn't, through their agency, have access to the vaccine. We are currently operating as a safety net as we continue to build our platform in anticipation of providers getting access to the vaccine so that they can begin to support some of the prioritization vaccines that I will share later on in the presentation. I'll move to the presentation now. So this is a quick COVID update presentation that Drs. Gale, Crowell, and I put together to demonstrate and to illustrate some of the challenges where we are with our vaccination plan. Similar to our testing plan and our ramp up, we've used some of the lessons learned from that initiative. We've also looked at those other jurisdictions, those states throughout the country who've had challenges in trying to roll out vaccines in various populations. And so we're using that to inform some of our decisions, to make our decisions better, to make our prioritization targets more robust. And so as you see, so the priority group status, we're still heavily engaged in our prioritization 1A, which includes our hospital and assisted living and our urgent care workers. As you see the number of vaccines administered, we are number 2 behind Baltimore. So just to give you a snapshot of where we were using the vaccines, we received 12,900 vaccines to date. By Friday close of business, we had vaccinated or administered 8,939 shots in county and arms. That's about 69%. As of close of business yesterday, with our numbers, we were around 10,787. It may be adjusted as we go through the slides. I think it's slightly higher than that, but we're sitting around 80%, 83.6% of all the vaccines that we've had and used to date, including our clinics today, and absent of physically receiving those vaccines that we've anticipated to receive this week. We will be at 100% use of the vaccines that we've received to date. We rank number 1 out of all 24 counties with the administration of our vaccines. We have 2,192 plus appointments scheduled today. To date, as I indicated, we received the most vaccines of all the counties at number 1. We've administered 80%, and we expected to receive that 6,700 allotment this week. Now, keep in mind, as we receive data throughout what's being reported, the reports that we received throughout COVID vaccine summary report from the Maryland Department of Health lags in a day because they have to retrieve the information from the system to update their data dashboards as we're having to do real time. Our current daily capacity is targeted at 2,500 to 3,500 vaccinations based on the appointments that we allow in the system. We have tested at White Oak Recreation Center, Up County Recreation Center, Germantown Recreation Center this week with our Public Safety Training Academy, and then Friday at Quince Orchard High School. And we're working on additional vaccination pods in collaboration with Kaiser to look at vaccinating some of the healthcare professionals that we have and other individuals under their prioritization categories. We've also had conversations with the hospitals who may or may not use their allotment of the Pfizer vaccines, which we don't have. So we've requested and had conversations. We have a conversation this afternoon to see if some of those doses can be used to vaccinate our prioritization levels and within those tierings. We've also had a conversation with the Federal Drug Administration to look at vaccinating some of their staff so that we can, again, look at the support providers, systems, agencies in the county that can help move us faster through our prioritization pyramid and vaccinate more folks. again, illustration of where we are in the amount of doses that we receive. We still rank number one as the amount of doses that we received to date, and slightly lower as far as administered, and that's hampered by the scheduling and the allotment upon receipt. So as soon as we get them, we have the appointment scheduled, we send out the notifications. We even open up the wait list in many of our vaccination pods to allow folks who are waiting on the wait list sufficient notification so that they can attend and come and get vaccinated. We have our schedule stratified so that we can get providers, healthcare professionals, and other individuals who have received an appointment either before they go into the office or their front facing place of work, as well as into the afternoon as late as 7 p.m. This is just an illustration of the allotment of vaccines administered through the hospital systems in the state of Maryland. Just a quick reminder to the council regarding those prioritization, those current prioritization levels for a priority group 1A includes hospital personnel, staff, developmental disability, assisted living facility, rehab facilities, and this partnership is through directly with the state of Maryland and pharmacies for those congregate living spaces, those long-term care facilities, and those assisted living facilities. The hospitals receive their doses directly from the Maryland Department of Health. And we're responsible for testing a wide range of folks, and that's why we are pushing to get more doses, to get more vaccinations, more shots in the community, and we are using our allotments as soon as possible on a scheduled pace. Our current range, again, is 2,000 to 3,000 plus doses with support to the providers to assist us as we, again, move through those prioritization levels and those tierings to get folks the much needed first doses, let alone the second doses. Our priority group for 75 and older, we've begun to have conversations around that. We have our agency and developmental disability service area helping us to plan for that prior to actually moving to that stage. As I indicated before, we are based on the allotment, which drives most of our vaccine planning. We're a couple of weeks away from that, but we're planning now. We're planning now to vaccinate individuals age 75 and older. We've had discussions with our agent and disability to look at transportation, to look at various strategies to help them get to our vaccination pods. Some of the strategies include having dedicated pods for this particular category and prioritization. I even had a conversation briefly with Dr. Stoddard yesterday to look at emergency management and homeland security, possibly supporting and having staff have pods at assisted living or those facilities that aren't in the CVS pharmacy partnership with the state of Maryland. And so we're looking at possibly having a dedicated line for individuals, senior individuals to contact and have it solely dedicated to not only 65 years and older, but 75 years and older, but those individuals 65 years, and a dedicated line access point for our senior community. And our priority group 1C is as follows: tier 1 individuals who are 65 years and older, individuals 16 to 64 who have underlying health condition, and those essential employees not covered in the other tiers. And so I will stop now and turn it back to Dr. Crowd and for any additional questions.
James, would you put up the last slide, please, in your deck? A little bit, yeah, there we go. All right. So I want to start by just backing up to saying, Council President Hucker, I'm sorry to hear that you have COVID, an uninvited guest into your house, and I hope that wherever that infection is, that your family members are recovering quickly, so that you don't have to wear a mask around the house. So Dr. Bridges has sort of walked you through all of the issues. There are a couple of things there that I wanted to highlight around this about moving forward, and that has to do with where we are in first and second dosing issues. And this is a sort of walk through this process a little bit. The first 3 weeks, you'll see our first doses ramped up, 100, 4,200, 8,600. That 8,600 dose was in response to how quickly we managed to put out the 4,200 doses that we got in the second week of our operation. And the request that was made was, how many can you use? And Dr. Gales put forward a range for folks, being not knowing where to go with it. He just put forward a range for folks for that week, and said somewhere between 6,000 and 10,000, and they gave us 8,600. That following week, for this week, that 6,700 dose was based, as James has noted, that we asked for 12,000. And that's what we got. And I'm advised that reductions took place across the state, so we were not alone in that. It had nothing to do with how many doses we put out in the previous week. There's a disconnect. There's nothing to do with that. So just wanted to set that record straight because it's been floating around, and the question has come up a couple of times. And to also just say, there is no universe that I'm aware of in which Dr. Gales would ask for fewer doses than he'd gotten the previous week. The goal here is to grow and continue to administer doses. So there's a little of that floating around as well. So no, this was a state decision, and why the state reduced doses likely has to do with how many they got from the federal government, but we're not sure yet. So the other thing about this chart is that as we move forward, we are now either this week, and I put it in this week, this may need to be adjusted, but either this week or going forward, going to have to start administering second doses to folks who have gotten the first dose in the first few weeks of this operation. And what you're seeing here is a reflection of what now has to happen with folks who've gotten first doses, that as we go forward, the number of people who are getting second doses is going up. What we don't know is how many doses the state is going to send to us to continue doing round one dosing, and what that total number of doses is going to be. That is a function, I believe, of what the federal government is going to send them. I did get a news alert while we were talking that the current administration has decided it will not hold back second doses at the federal level. So they are sending a message that they intend to move ahead of the Biden administration and begin to release those second doses. So that was from the Washington Post a little while ago while Dr. Bridges was talking. So I think the message is that they intend to move those first doses ahead, which means hopefully that we will get additional doses. But going forward, what this means is that every additional week, we are now adding more and more, assuming those numbers in the first doses go up, we're going to be adding more and more doses that have to be given out as second doses in subsequent weeks. Thanks, James. You can pull that one down for me. So I wanted to sort of give you a sense of what's coming and what we're working on around this. And it's one of the reasons that Dr. Gales and Bridges and team are working to identify providers at hospitals and with Kaiser and with other groups that will be able to help stand up the county effort for vaccination and help to distribute those doses. One of the things about this is that, well, I'll start with a bottom line ask. There's some conversation about seniors, and I'll jump into that in a second, but I wanted to say that our bottom line ask to council is that if you're advocating anything, it is that the state activate access to primary care providers for the network so that they can get into Immunet, so that they can begin to vaccinate their patients and patients more broadly. It is only when that primary care system gets activated that we're going to be able to really see broad scale vaccination across the county and across the state. So that's important for the population that we're talking about, seniors age 75 and over, age 64 and above, and for the general population as we get to it. We are working, as Dr. Bridges mentioned, on a plan for 75 plus. We still have an estimate of about 15,000 or so healthcare providers across the county that need to be vaccinated. knowing that not all of them will sign up and or come in, we are, but if I assume that number, we are close to being through most of the healthcare providers that we need to get vaccinated in tier 1A, which means we are going to be able to move to 1B fairly soon. We are looking at probably across age 65 and above, we're looking at about 180,000 seniors, not all of whom will need to be vaccinated by us, but we are looking at that as our number. There's a range of things that we're working on, including some pre-registration conversations about how do we get people so that we can begin to get people into a system, so that we can triage and prioritize and invite folks in a way that is very much unlike the events we witnessed this past week in Florida and Texas, where there was mass chaos because they simply said, come in. We have to do this in a way that is actually methodical. It looks simple, just open it up and invite seniors, but behind the scenes, there is a lot of work that has to happen around that. And the team is working to make that happen pretty much in real time. So it'll be a moment or two before we get there. But we are working on that. So we certainly answer any questions you have about that. The last piece of this is just to reaffirm, to say, first of all, thank you for channeling questions to us and giving us time to answer them in a more methodical way, so we can allow the public health team to stay focused on the process of ramping up. A lot of useful and interesting questions in this that need a response and deserve a response that we can answer with our team. So we're thank you to Linda McMillan and for Councilmember Hooker or Council President Hooker and Council Vice President Albernos for helping to funnel those questions to us and giving us an opportunity to work through the answers. I believe Ms. McMillan has sent over a first iteration of responses. All the questions are not answered, but we will continue to answer them and send them back to you so that you have those as we go forward. So I think I'm going to stop there and turn it over to back to you all, Council President Hooker, for the questions, or moving to Dr. Stoddard.
Thank you so much, Dr. Crowell. Thanks to all three of you. Dr. Stoddard, you're next, I believe.
Yeah, I only have a few updates. I'll stay mostly focused on vaccines. I'm sure that's where all the questions are at. On the website front, more than 28,000 residents have signed up for the alerts. The first alert will go out to them hopefully while we're on the call today. It's actually in draft form with public information. It should go out in English and in Spanish. It'll be a little more quick moving forward, but obviously it's the first time getting the information together. So, a little bit of bumps and everything as we go through the first time. The priority groups website is finishing up translation, I believe, in the normal 7 languages that we have on our website. So that should be done over the next couple of days. We did have a meeting yesterday with the Medical Society and Healthcare Initiative Foundation and others to talk about communication strategy and how we can leverage their work to really further the communication effort to get it out to more diverse communities. It was great. There were representatives from the Primary Care Coalition and some private providers who were on that call as well, talking about how they can be of service. And one of the things I think that we learned that I think was really important is that the philanthropic community is really interested in getting more engaged on this vaccination distribution front, which will become increasingly important when we have more vaccine to distribute. Just a couple of things I really want to hammer home, and I think this is just important for everyone to understand in the public. The goal that Montgomery County has as a partnership led by Health and Human Services, but with partnerships from public safety and elsewhere, is whatever vaccine we receive on one Tuesday is out the door by the following Tuesday, so that we can we never are backing up on vaccine. So when we receive our allotments, we schedule out the clinics based on what's available. My sense is, given that we're only going to have 6,700 doses, there is a very good possibility that we've given out all or potentially the vast majority of by Friday, meaning that there will likely not be clinics Monday and Tuesday next week because we don't have vaccine to give out until the state gives us more. And so I want to be clear that, we're not holding back vaccine. And frankly, we've had discussions about if they increase the amount of vaccine that is available to us, we'll begin doing weekend clinics to give that vaccine out, because obviously we know that that is going to be necessary to ramp up. But until we have enough vaccine to justify scheduling and bringing in volunteers and all of those things, it's really, we could schedule weekend clinics, burn out staff, and then have nothing for them to do, no one for them to vaccinate on Mondays and Tuesdays. And so we are prepared to ramp up as a partnership. As Dr. Kroll said, there is a limit to that, and so the private sector is going to be absolutely necessary. The private healthcare providers are going to be absolutely necessary to really push the numbers that we want to see. But we are not at all at our county limit, nor do we think we'd be at our county limit for some time. The limitation right now is the amount of vaccine that's afforded to the county to distribute. As the slides that Dr. Bridger showed, Montgomery County has more than doubled any other health department in the state, and frankly, the number 3 is more than triple. And so, if it weren't for Howard County, we'd be a bar in and of ourselves. They're at least half what we are right now. So, the work within public health, I think it is, the work that's been done within public health, I think it deserves the credit it is due. It has been exceptional. And I do not think, I think that any sort of suggestion that they haven't gone well out of their way to do as much as they can is wrong. Public safety partners are starting today. I will say, and I think this bears continuing monitoring. They have 3,000 appointments Tuesday, Wednesday, and Thursday this week in combination. Those appointments aren't filled at this point, which has us somewhat concerned about how many of our public safety partners. There are about 7,000 in the county when you consider the municipal and state partners. And the fact that we didn't fill out all 3,000 appointments immediately has us a little bit concerned about where we believe we're going to fill out the 3,000 this week. But I guess the question is whether we are going to be able to vaccinate 5,000 or 4,000 or 3,500. I don't know the answer to that question. We're going to have clinics with public safety partners again next week, but I think it's pretty clear that we're going to start integrating in additional other partners into those clinics to fill out their appointments, because the public safety agencies, the uptake in them has not been as robust as we would have hoped. I very much hope I'm wrong about that concern, and I think we all are, but I think we're going to have to be realistic and make sure that those vaccines aren't just sitting there waiting for people who are not showing up, and we will not do that. And I just want to make that clear. So we'll get people into those clinics starting next week, and we've already had discussions. I had discussions with Chief Goldstein this morning about after we finish up public safety and whatever other organizations next week, the following week, maybe getting them on the road and doing some things in Leisure World and Asbury and other places where we know we have our 75 and older residents. And so Fire Rescue is very much on board with that notion. And so we'll talk with public health that this is something we're working on in real time, and be able to get back more information to you as we're prepared to talk about it. But they're very much interested in doing that and vaccinating whomever they can. They know their capacity about 1,000 a day, and they've got the staff and logistics all ready to do that. So I'll stop there and we can entertain questions.
Thanks, Dr. Stone. I just wanted to underscore this issue about the weekends. We are at a point, given the number of doses that we're getting, we can either vaccinate over the weekend and have nothing to do on Monday or Tuesday of the week, or we can give our staff a chance to rest while they can, and then bring vaccination back online Monday and Tuesday for the existing to finish off the remaining doses that we've got. We will be going to weekends. There's no question about that, and not in the not too distant future, we're going to have to do that. So as more vaccines become available, we will decidedly do that. The other piece is that public safety is a work in progress for us. So we'll have to be as nimble as we can about moving vaccines into places where we can make sure they get delivered. So we will make sure that happens to the best of our ability.
And just to add a couple of points to that I neglected during the presentation around testing. We've had conversations with Mr. Madaleno has followed up prior to the holiday break. We received point of care testing, but we didn't have a clear Clinical Laboratory Improvement Act / amendment waiver to deploy those point of care kits that we've been waiting to receive, and we finally received them. And we have the initiative to identify those shelter spaces, those homeless shelter spaces, those behavioral health and crisis center spaces, and those construction spaces, targeting using those point of care tests. And so we are going to initiate that to again stem the transmission, community level transmission. One other piece, we had a conversation this week with a vendor to provide home test kits. And so we're looking at providing and distributing home test kits in those highly impacted priorities that we have used as a strategy to get more folks tested along those lines. So we're using and evaluating our systems. Thank you, Dr. Stoddard and Dr. Crow, for acknowledging our public health systems. And it is a community of practice, a partnership that we're not only trying to test folks, but get folks vaccinated. So I'll stop there, but I just wanted to add those two pieces about our testing strategy.
Thanks to all of you for all your hard work and dedication to this. Let me call on the Council Vice President.
Thank you, Mr. President. Let me just start by acknowledging and thanking our public health officials who have been working tirelessly, obviously, through these last 10 months, and especially relative to the rest of the state. There is no question that the infrastructure that we have set up is effective in our turnaround time once we receive the vaccines and getting them into people's arms. That is undeniably been very effective. I also appreciate the efforts over the last few weeks to improve the website communication. I think the registration system so that people can receive alerts is effective and helpful. And as I said recently publicly, I feel like we are doing a reasonable job of controlling what we can control. But as has been stated, and as we have talked about on numerous updates and briefings, there is a lot we can't control. And so I to the residents that have flooded us with emails and correspondence since the Washington Post article just this morning, which stated that residents in Northern Virginia and in the District of Columbia have already begun their phase of being able to provide the vaccines to people over the age of 75. There's just understandable frustration, confusion, and frankly, growing anger that our state has not been able to move more quickly. And so I guess my question primarily for the team is, why is that? Was it a policy decision at the state level? As of yesterday, Virginia had administered 180,000 shots and Maryland had administered 140,000. Did Virginia concentrate most of their doses to the areas with the highest concentration of cases around Northern Virginia? And while we have received a larger share here in Montgomery County, there has been a more even disbursement across the state, even to within jurisdictions that haven't had anywhere near the level of community spread that we've had in some of the larger counties. So to the best of your knowledge, is obviously, and it's also troubling that we don't know exactly how many vaccines the state has at its disposal, and in some ways are flying blind in terms of how we're able to administer our own vaccines here. I do have specific questions to our operation, but before I get to those, if Dr. Stoddard or Dr. Crowell, any one of you, or Dr. Bridgers, any one of you is in a position to describe from your perspective what the state's approach has been from a policy perspective in the administration of the vaccines, which is directly tied to why we are still in 1A and other jurisdictions have already moved on to their next phase.
Sure. Thank you, Council Vice President Albornoz, for that question. To the best of my knowledge, and in conversations with Dr. Gales, and he's been in more conversations with the other health officers across the local jurisdictions, my understanding is that some of the smaller counties who receive their doses and have the capacity to move to 1B were asked to hold. And I don't have the backdrop or the story around that. I know that they're trying to move in unison, but in some jurisdictions it may hinder on the progress in other jurisdictions. And so I do know that Most of the guidance and policy is set by the Maryland Department of Health, as well as the allocation of vaccines. And that's as much as I'm able to share during this briefing to council this morning.
So the bottom line, go ahead, Dr. Stoddard.
I was going to say, I think that Dr. Bridgers has it correct. I think in my view, the state may have misestimated where the priority group populations were. And so you had jurisdictions that received more doses than they had people in category 1A, and were able to complete those over the first week of vaccinations and have extra doses that they wanted to move into category 1B with. I think if those distributions had been more accurate in their distribution across the state, we would be further into our 1A and they'd be finishing up their 1A, and we would be all in sync. And now we've got this discongruency that is emerging over the state, where the larger jurisdictions with more primary care providers or more healthcare workers are lagging in terms of percentage relative to the smaller jurisdictions who are fully through 1A. And so I think if those estimates had been better earlier on, you would have a more even distribution of jurisdictions ready to move into phase 1B. I don't think it's going to be a vastly different amount of time. It's going to be a matter of weeks, but I think when we talk about weeks right now, that's too long. And I think we all agree with that. I think we would absolutely like to be have had more vaccine, and we would be through 1A at this point if the distributions have been more accurate.
Yeah. I can't speak to just one other thing. I can't speak to Northern Virginia's Virginia and their process around how they did the allocation. And talking with my counterparts in human services around health and human services around the state, they are as equally in the dark about sort of the process and the flow and the state's decisions about distribution of vaccines as we are. DC, of course, being both state and local, manages that process, and with a much smaller number of healthcare, much smaller population, both in terms of 1A and others, their ability to move into 1B is not surprising given the size of their population and the number of people they have to vaccinate. We are moving pretty fast with getting through our 1A, and I think we will continue to do that and get there and get ourselves into 1B over the next several weeks. I'm certain. But it just takes us longer. We've got a large number of healthcare providers.
And I would also note one big thing too is we don't know what the uptake rate is in any of these jurisdictions, meaning that we may be in 1B in a week from now because we don't get as many people coming in through this, tier 3 category of 1A as we thought. That's not particularly good news. I mean, it would be good news that we got into the 75 and older population, but it would also mean that there would be a substantial number of our primary care providers who are refusing to take the vaccine, which has other implications because they would then potentially not be advocating that their patients get it at a later point if they're unwilling to get it themselves. And so obviously we're kind of hoping our number of our primary care providers come in and get vaccinated. Maybe that takes a little bit of time because so many of them are interested, but I think we don't know that until we start taking those folks in and having them come in and get vaccines and taking those reservation slots.
So needless to say, it's frustrating is not the right word. And there needs to be accountability at the states. And so I think we are going to have to work with our delegation in ensuring moving forward that there is accountability for what has transpired. To Dr. Bridger's point, we have the capacity in Montgomery County to provide between 2,500 and 35 vaccines per day. That's 17,000 to 24,000 per week. And last week we received 6,700 vaccines. And we are hoping to receive 12,000 in the upcoming week. So it's clearly a supply and demand issue, and the state needs to reallocate and pivot its policies immediately in order for us to be able to vaccinate the regions in which there has been the highest concentration of spread, the greatest amount of deaths, and it is absurd that we have not been able to achieve that. And so my frustration is not to our public health team, but to our state officials who have not been transparent, who have not provided clear communication, and who have not been doing their job. And so that needs to be addressed, and it needs to be addressed right now. With regards to pivoting to local communication, Dr. Crowell, I appreciated your comments with regards to establishing a registration system to avoid the pitfalls that we have seen in Florida and frankly, even some of our neighboring jurisdictions who are, understandably being overwhelmed by requests from people within that category. What is the time frame for the type of registration or technology solution that we are exploring right now? Are there additional resources that are needed to be able to stand something up so that whether it's a week or 2 weeks from now, when we finally can begin to administer the vaccines into our older adult, more vulnerable populations, we are better prepared than other jurisdictions based on those lessons learned?
So I'm going to say, obviously, I'm a healthcare professional, clinical psychologist, not an IT person, but this is there's a technical solution that has to get put in place around this. I believe that we should be able to adapt some of our existing solution to get folks pre-registered in our system, and then we can move them into the PrEP mod system when it is their turn to be registered. That is a system that basically identifies folks by age, by date of birth, by age, by race and ethnicity, by zip code. There's a few demographics, and by any kind of special needs, I think, that they might have, so that we can get a sense of the numbers of folks that are interested and the numbers of folks that we would prioritize. So it'll take a minute to get that technical piece in place in operation. I'm guessing, it's a week to 2 weeks, but I'm not sure. It could be a matter of days, just depending on how much adaptation to our existing system has to be done. That, I think, the good news on that is that while we will have to take the time to get that in place, my sense is that as we progress through layers and tiers of the population, when we go from 75 to 65, the adaptation will be a minor adaptation that allows us to expand the eligibility groups. So it could be a very minor tweak in our existing process. So that's the piece I can't answer for you right now.
Okay. Obviously a high priority. Dr. Stoddard, you were going to say something.
Yeah, I was just going to say, I think it's important for us to understand, even as we may be able to get into the 75 populations sooner, depending on what the healthcare, because obviously we've talked about the Southwest model for boarding where you're not going to wait until all of one category is through. But I think the key thing to understand is with every new group that's added on, it'll be while one group is ramping down, the other group is ramping up. And so the initial allotment for, initial ability to get to 75 may be very limited, and it would expand thereon until we got through everyone. It's just important for everyone to understand that it wouldn't go from doing nothing in one group to doing all of the group the next day. It will be a transition out of one group and a transition up into a new group. I think it's just important.
The other, you're right. And the other piece of that is that just in terms of a registration system, any kind of system we set up, we also have to set up a process for how people and when people can log on to register. We do not want to have a system where everybody rushes the system and crashes the system, as we saw happen in Florida. I think we're not in any real danger of that, but structuring how people come into that system is the other piece of this we'll have to do. So it's not let's turn this on tomorrow and let's say to everybody, come get in. We also, some of the other problems we have to solve around this will be dealing with folks with limited access to internet and technology, and folks who are, like myself, a digital tourist rather than a digital native, and the support that they need. So it's whatever we're doing in terms of online, we probably are going to have to match with some call capacity. So this is, to Earl's point, we're going to be building this in stages as we go forward. Starting with the online piece, but then moving out to other things.
Okay, I appreciate that. Just just two other points for context and then one final question. So just in the last 12 hours, the CDC has announced that they're not as concerned about the length of time between the first and second shot. In other words, and then that was followed up by an announcement just as we were talking from the federal HHS that there's going to be a higher degree of rollout so that more people can get that first shot, given what the CDC has announced. So that hopefully will mean states will receive larger percentages of dosages more quickly. That's a significant policy decision at the federal level, which will trickle down and improve rollout. Should have been done obviously before, but that is good news. Final question is relative to our developmental disability community, which everyone acknowledges, and I do appreciate the governor placing them in 1A, along with the service workers, and acknowledging this congregate living facilities, particularly within our disability community, have a disproportionate impact. Also acknowledge that they have been directed to Walgreens, CVS as part of the federal program, based on the policy that has been laid out by the state. But understandably, from the developmental disability community, there's tremendous frustration because, of course, Walgreens and CVS have not been able to stand up their tests yet. And so they're being directed to operationally a group that can't help them. And so my question for our team is, should we consider, given that Walgreens and CVS has not been able to stand up and has not even given a time frame for when they're going to receive their dosages of federal vaccines, including them within the county's response, particularly Dr. Stoddard, given that it looks like there are some slots being unfilled. Because as we saw early on in the pandemic, there is tremendous spread that occurs within this congregate living facilities, nursing homes, group homes. Should we be exploring that, acknowledging that goes against the stated state policy, but doesn't help the folks that are on the ground experiencing this crisis?
So, Councilmember Avernos, I'll respond, and Doctors Crowell and Stoddard can add. I've had multiple conversations over the last 4 days with key stakeholders, specifically Dr. Greenberg, about the same thing. And so, if there are doses available, we at the local level continue to be the safety net, and we would look at those appointments and those scheduling. We're working on a plan. We're having discussions about that very same thing. If those appointments are available, to allow those individuals who work in those congregate spaces the opportunity to receive a vaccine. So we're working on that as we currently speak, and we have addressed the need, and we will present that yet again to the Maryland Department of Health as a shortcoming regarding the most vulnerable populations.
Well, I would add to that the challenge for us first is to get a clear sense, an absolute clear sense of what the state is and is not going to do and is ready to do, so that we don't get cross-wired with them, and start confusing the public around in messaging. So that the first task is to really get clear with them so that we can put out a public message about what they're going to do, and then we can make offer some clarity about what we can do to backstop that if there's a gap. Assuming
I think adding to Dr. Kroll, adding what Dr. Kroll just said, I think it's really important. It's not just what they'll do, but along what timeline they'll do it. Yeah. I think that's what we're really trying to understand, is because our understanding is that the nursing homes should have all received first doses at this point, and they should be moving into assisted living facilities and presumably then onto DDA providers. But obviously, we would feel discomfort. We've talked about this moving into our phase 1B if there are still organizations in phase 1A who, through the federal contract or through the state effort with hospitals, we're not getting vaccinated along the same pace as other 1A providers. And so, as we are moving towards a completion of our efforts in 1A, we're trying to understand whether everyone who's receiving 1A prioritization, whether it's through us or elsewhere, is having that opportunity provided to them. And so we absolutely are committed to making sure that DDA providers are covered as part of 1A. And I think we've all expressed a recognition that if we have to step in as a county to help those providers, we will do so in the same prioritization.
Well, I think we should add that to the list of grievances with state officials who've not made things like this and that have real practical implications for providers more clear. And we need to do that today, because if we don't get a reasonable response within the next 24 hours, then I do think we're going to need to move forward with administering these vaccines to this highly group that's significantly at risk, as we all acknowledge. That's why they were put in 1A in the first place.
I wanted to raise a point that to do that means that we are delaying the onset and the degree to which we move into 1B, so into the 75 and older population. So there's an issue around that. It's not. I don't know that it's that the number is all that great, but if we do that, then we are going to delay. It will add to the number of folks that are in 1A and lengthen the time we are in 1A before we can move fully into 1B.
Understood, but we gotta deal with the issues that are on the ground. We can't just wait for the state, and so that seems pretty clear at this point. So go ahead, Dr. Sardi, you're saying one more thing.
Yeah, I think just one quickly state. It's really important to understand this is a federal contract, and the state does have responsibility here. But I think we also need to be working with our federal delegation to be putting more pressure onto the federal HHS system, particularly as we get into the new administration, to ensure that they're moving more quickly along that contract. I think that the state has an ability to apply pressure. I do also believe that we need to be working with our federal delegation. I'm actually texting back and forth with Ms. Connor from Representative Raskin's office to try and put some of that kind of pressure onto that federal infrastructure as well.
Thank you. Apologies to my colleagues. I know I took up a lot of time, but I defer back to you, Mr. President.
Thank you, Councilmember Rice.
So thank you very much, and thank you, Council Vice President Albornoz, for your questions surrounding vaccinations. I'm going to take a different route. I want to talk about children, and something that I've seen that's very troubling and concerning to me. Since last year, we've seen an 800% increase in the cases of COVID and hospitalization rate of COVID cases involving children. We've seen this illness, MIS-C, the multi-system inflammatory syndrome in children, after children have contracted COVID at an all-time rise. We've seen record numbers in Florida and Louisiana and Michigan and other states all across the nation. And in fact, we've seen a roughly 13% increase over the past month in hospitalization rates regarding COVID cases in children. Can someone tell me whether or not we're tracking this as we look to say that vaccinations tend to be a sort of green light for us to move in terms of school opening? Should we be pausing and looking at what's happening and the number of cases and the rises in COVID regarding children?
So I'll start with that, Earl. I don't know who wants to chime into this, but I'll just tell you that I'm always mindful of the challenges we have with children and what we're in the directions we're not looking in. As we start talking about reopening schools, I believe that the priority around this has been focused on making sure that our teachers and support staff at the schools are vaccinated as a priority to keep them safe. And then, of course, looking at the criteria that the schools are setting for how they're going to maintain boundaries and space between children and all those added factors that we've been talking about for 10 months, how they'll play, how those things will continue to be implemented, and the importance of continuing to implement that even post-vaccination. I am obviously concerned about what happens to our children, both short-term and long-term. And also, I would say that there is at this point no vaccine approval for 16-year-olds and younger. So that is a significant challenge that we face. I do believe, I think Earl and I have had this conversation a time or two, that we can expect that there will be some approval for vaccination for children, younger children, in a few months as they get more data, more information about the vaccine, but it's not there yet. So we obviously, to your point, need to be mindful about, and the state needs to be mindful about the impact on children and bringing them back together prematurely in large groups. Our younger children are more obedient and more compliant around mask wearing than our high schoolers are, and then perhaps our late middle schoolers as well. So it is there's some variables that need to be considered in that in terms of how we bring people back. But in general, we need to proceed with some caution on this, I think.
Yeah, I would say the picture among children and young adults is complex and not fully understood. And I think that, and I say this, there are people in our community who send articles of interest to myself, Dr. Gales, I'm sure Dr. Kroll gets them as well. And while I don't respond to everyone who sends in articles, I definitely try and read as much out there just to understand what people are reading in the community. And I will say that we have gotten very strong advocacy on both sides of, I'll talk about education from the issue there, where they try and illustrate that there are problems amongst children, and there's a strong base of evidence to suggest there is not as many problems amongst children, and there's a higher rate of asymptomatic cases in children. So there is a constellation of those things that can be both true, depending on the nature of the question you're looking at. What I was just pulling up the numbers in Montgomery County to see where we were at Right now, approximately 5.5% of our COVID cases are children's ages 0 to 9. That has been relatively stable around 5%, frankly, since about May. It goes up and down slightly, but it's increased. I mean, it was literally 5%, I think, by around May 15th, and it's been right around that number since then. In children ages 10 through 19, I obviously include some adults at 18 and such, we're sitting at 8% of our cases. And give you some context there, children on 0 to 9 are the lowest percentages. Adults 40 to 49 and 70 to 79 are above those children, and then the next highest is 10 to 19. So it's actually 2 of our 4 lowest are actually in children. Now, obviously, the story is incredibly complex in education. We continue to look at this because we obviously talk with MCPS all the time about this issue. What they're seeing in Europe is a very mixed story. What the papers indicate out of Sweden is very different from what the papers indicate out of the United Kingdom right now. And particularly as it relates to the intersection between children in those environments and the teachers and staff who work in those environments. That, I think, is where the greatest lack of understanding is. So I think in total, what I would say is children are less likely to see severe outcomes than adults. There are going to be severe outcomes in children, that is without question. I think I would say the long-term implications of COVID for young children and adults is still very poorly understood. It is entirely plausible that there will not be as many long-term implications for children, but that is certainly not, we don't know that yet. I think we do know that the relationship between community transmission and what happens in educational environments and amongst children by extension is also complex. I think there are a number of studies that show that you can operate at a fairly high level of infection, but there are also a number of studies that show when you operate at a higher level of infection, you see higher levels of infection in the school environments as well. And so it is a very complex picture. I agree with the sentiment. We've talked about this before. We want to get children back into school for educational perspective. That's where they do receive the best education. But I've said this before, I think my biggest consternation is we know that there's going to be substantial educational loss at this point, and that's a big concern. What we don't know is what the medical and long-term health implications of putting children back in school are. And I think that's the biggest area of uncertainty. And finally, when we talk about schools, and I think I mentioned this a little bit, is we cannot forget about the faculty and staff and the risk posed to them by putting them in this environment. And I'm not saying necessarily that it's more risk than a grocery store worker, but there's certainly data in the United Kingdom that says it was 333% more likely than the average worker for some school districts in the United Kingdom. Granted, the United Kingdom has not worn masks in schools, which is a decision that is beyond the pale to me. But that's why I think some of these situations, we're trying to understand the data. The data is complex. The data is challenging, and you can find data and publications and papers and peer-reviewed studies that support any conclusion you want to make about putting kids in school. And I think that's the really challenging thing.
So, Councilman Rice, one last thing I would add to that is that very mindful of the mental health impacts of kids being out of school and being pinned down and locked into their homes and in quarantine, both in terms of socialization and in terms of their ongoing behavioral health problems where they had them. We have a group that is beginning to meet to work on thinking about strategies and how we support our children continuing in a more deliberate way and coordinated way, working with MCPS and our HHS departments and REC and other partners to sort out what we can do to support them and give them some relief from what is going to be a continuing challenge over the next couple of months.
So the reason why I asked this question, and this is really important, is because we at some point are going to have to determine a strategy. The council is going to be presented with Montgomery County Public Schools budget that will extend into the fall. And so we'll need to figure out what is it that we're going to do and what are we deeming as safe. The reason why I bring this up is because while, yes, we can look at studies and say, well, you can assume this or that, I was talking specifically about the numbers. So Dr. Stoddard, you had mentioned that in the age range of 0 to 9, that stayed stable at 5.5. You didn't say whether it was stable at the 10 to 19 and whether or not it had been that consistent, because nationwide, I'm not talking about Europe, I'm not talking about other countries, I'm talking about here in the United States. The reports in Newsweek and others have said that there's been, over the past month, a significant increase in cases amongst children. And so I'm trying to find out if we're seeing that here, and if so, what we can extrapolate from that sort of increase.
In the 10 to 19 category, it's actually been decreasing. We also, it started out in March, we were sitting about 4%. In September, it spiked all the way up to about almost 16% of our cases were in 10 to 19. And since then, it's been mostly on the decline to where we're at 8%. In fact, in beginning of December, it was a little over 10%. So we've seen about a 2% decrease since the beginning of December. But if you're looking to, understand, we don't have as many schools open right now. Our public school system is not open. And so I don't know this to be the case. I'd have to look more at the data that you're talking about, but it is entirely plausible that the spike that we've seen across the country may be related to what's happening. I will tell you this: there was a lot of research on H1N1 that was made, and there was some really great papers out of France where they showed the transmission in the communities before. And I realize flu is very different from coronavirus. I'm not trying to make that parallel. I'm simply saying, like, there needs to be more research on this. One thing they did see is a big spike in H1N1 in France after they brought schools back in together, because what happened is you disperse students for your holiday breaks, you bring them back in, they exchange whatever it is that they have amongst themselves, and then redistribute it to their community where they're at. I cannot say whether that's happening right now, and I think anyone who would suggest that would be scientifically irresponsible. But I think it certainly needs more study, and it is very plausible that it is the case that you're seeing a spike across the country because we've allowed for the Thanksgiving, the Christmas holidays, the end of year holidays, and New Year's to be sort of a mixing bowl, and schools and other youth opportunities, including childcare, are potentially an avenue through which that exchange happens.
Yeah, it is interesting that you bring about the point that Montgomery County has, in effect, over that time period that you're talking about, made significant restrictions. And those significant restrictions then resulted in numbers going down. And so my concern is, and again, we don't have the data to know, but if you start opening things back up, would those numbers rise back again? One of the other things, just to bring about, and I just want to say for my colleagues on the Education and Culture Committee, this is something that we're going to have to address sooner rather than later. So I am going to ask for Health and Human Services to come to the Education and Culture Committee so that we can have a conversation around what something like this may look like and delve into the data a little bit more. But let me just say that a lot of epidemiologists and others that I've talked to, specifically because I've been really trying to focus on this over the break, has been the underreporting of cases, understanding that children have very mild symptoms, if any at all, and so therefore may have actually contracted COVID, but because it hasn't presented itself in a very significant format, means that you're not counting those numbers, and the numbers are actually much higher than we've ever represented because of that. So again, you don't have to respond. I mean, it's something that I see you nodding, and it's something that we all certainly understand anecdotally makes sense. That, if you don't have symptoms, you're not going to go get tested. Why would you think so? You're not sick. So along those lines, there's a lot more to flush out. But if we are to be intentional about getting our kids back into school, we've got to get a handle on some of these numbers and some of this data, really start to understand why it is that we're seeing the numbers where we are, what we're seeing nationwide in terms of school systems that have opened, and how that can best guide us. And look forward to working with you, Dr. Stoddard, as well as Dr. Gales, Dr. Bridgers, and Dr. Kroll, to make sure that we can make the best informed decision in helping our school system and guide them in a direction that's going to be safe for our community. So thank you, guys.
Thank you. Councilmember Glass.
Thank you, Mr. President. Good morning, everybody. Thank you for the presentation. As my colleagues have stated very well, the level of communication that we all are receiving has been highlighting our constituents' frustration, anxiousness, and quite frankly, as I think Council Vice President and the chair of the HHS committee noted, their anger as well, as we continue reading about how other jurisdictions are rolling out their vaccines and helping to keep their residents healthy and safe. And so I just want to double back on a point that I thought I heard, and just want to make sure I understand even better, and to help everybody who's listening to this understand what we've been asking. Dr. Bridgers, I think it was you who mentioned that we have requested an additional 12,000 vaccines, but only received 6,700 out of that request.
Councilmember Glass, that's correct.
So we're getting about half of what we're asking for. That's what you're telling us.
For this week allotment, that's correct.
And because we only learn about our allotments on a week-to-week basis, there's no way for us to properly plan ahead and provide the types of schedules that other jurisdictions are sharing with their residents. Is that correct?
That is also correct.
Yeah, well, I appreciate you sharing that information with us, because we need the state to step up and provide us more of what we need so that we can better communicate with our residents and give them the timetables that they will quickly add to their calendars so that they can know when they can try to begin resuming some semblance of normalcy. And I understand some of the complications here. Maryland is a large state, but we're seeing larger states do more. And the equitable approach would be to provide vaccines to the communities that have experienced the most positive cases. Get the help to where we know the hurt is the greatest. And most definitely, Montgomery County is high on that list. And while we're already high on the list in terms of the number of individual vaccines that we've received, because we are the most populous jurisdiction, the pain here has been acute. And so as you and others have shared, some of the news coming down from the federal government, President-elect Biden wants to release some of the vaccines so that the second round of doses can be freed up. And apparently the outgoing administration is going to start some of that work. But we really need Governor Hogan to step up and provide us more of what we need so that we can communicate better with our county residents and provide them with some level of comfort and expectation, because we are feeling the anxiety in our emails and our tweets and all other forms of communication. And I appreciate you also sharing that we also need the state to activate the primary care providers. Can you just elaborate a little bit more as to, if the governor activated that, what would that mean on the ground? What would people experience?
So, Councilmember Glass, thank you for that question as well and comment. Once our providers receive access to the Immunet to request vaccines, that would give us a vast majority or an increased collaboration of those providers who are able to put shots in folks' arms. So as we progressively move through the prioritization levels and within prioritization levels across tiers, we're able to vaccinate more folks. And so once a provider, similar to a flu clinic scenario, they're able to go into the state Immunet system, request doses, and we can set up appointments and work with our providers to ensure that we are vaccinating those folks according to those prioritization levels and increasing those prioritization levels. So those providers would have greater access, and in turn, the community will have greater access to vaccines and having those vaccinations available.
I would also add, there's some real distrust of government, and some people may trust their private healthcare provider substantially more than they'll trust a clinic that's operated by the government. And so it would increase access, but would also help us with those people who may be hesitant for the fact, not everyone's hesitant because of dealing with the government, but many are. And so if you get it out into the community clinics and to our sort of, nonprofit clinics and things like that, then you'll see a greater uptake in populations that might otherwise not seek it through the government sites.
Bottom line is that it increases the raw number of places that people can get vaccines and the number of folks that are providing that vaccine, and pulls it into the normal healthcare system, and allows us to cover those gaps in the spots that we've talked about earlier, where people are uninsured or don't have a primary care provider or can't get to a primary care provider. We can become the backstop for that in the way we are for immunization around the county.
Well, it seems like a no-brainer to me that we need to partner with our primary care providers, not only for public reassurance, but also just to increase the capacity. And so, I'd be supportive of the council making that request officially, whether it is in conjunction with some of our statewide providers and the associations and whatnot. But clearly, it's the right thing to do, and we need to do better at our capacity building. And if we have partners who are willing to do it, I'm not quite sure why we're not. And then the last point I just want to make, because people have been asking me, and again, it was addressed, but just to re-up it, weekend clinics, recognizing that some of the people who have been hardest hit are still working. They are still going into their places of employment. They are still taking public transportation. They are still putting themselves at risk and their families every single day. And so the schedules that we have might not be accommodating to people who are working really hard to maintain a livelihood. But the catch, as I understood it, to weekend clinics is just the capacity. We don't have enough vaccines to justify it. Is that correct?
That's right. That's exactly. If we did weekends, then we'd be off on Monday and Tuesday doing with idle hands. We will be going to weekend clinics. I think it's just a matter of weeks before we start that process. It is dose dependent at this point. Once we get to a point where we can't get all of our doses out, and we in the timeframes we have, we will have to ramp up to weekends.
I would only add to that. I think part of our decision is that, and this is not the only reason. The more important reason is the lack of vaccine, but I think the other reason is, we could do, just for optics reasons, we could do weekend clinics and have nothing on Monday and Tuesdays. But at the same time, we view our vaccinators as human capital, and we have utilized those resources extensively in our contact tracing, in our testing, in our working with, whether it's childcare providers or correctional facilities. They have not. This isn't like we break glass and open it up and we have vaccinators. These people have been working incredible hours up to this point, and so we will put them into overdrive when we need to put them into overdrive and work them on weekends and things like that. But at this point, we would be burning them out for no reason, because we would get through no more vaccinations by doing it.
We're going to ask them over the coming months to do a lot more. Right now, we need to give them a chance to get to take the break while they can, because in a few months, it's going to be all on all the time.
And we already thought it was all on all the time over the last 9 months, and we're going to be requiring more. And so I'll just conclude by thanking all of you, thanking all of our frontline staff, our government workers, our nonprofit partners, and hopefully we can bring more private care physicians into this as well if the governor were to open up for the primary care providers as well. So more to come, more to ask for, and hopefully our calls will be heard. So thank you all very much.
Thank you. Councilmember Jawanda.
Thank you, Mr. President, and thank you to my colleagues. Many really thoughtful and good questions, and thanks to all the public health staff, Dr. Bridges, Dr. Crow, Dr. Stoddard. Always really appreciate your thoroughness and your work, and Dr. Gales and team in their absence on this call. just want to be very clear because I think, it's easy to forget some of this stuff. So we've received 12,900. So a couple of rapid fire questions, just 12,900 doses to date from the state, right? Correct?
Correct. That's correct, Councilmember Jawando.
We've administered 9,500 or expect to administer 9,500 by this Friday, or was that last Friday? Where is it? How many have we administered?
So as of yesterday, we've administered 10,317 of the vaccines. As of last night, we have an anticipated clinic scheduled today of over 1,020 doses, which includes the remainder of the doses that we didn't administer yesterday, and waiting for the anticipated doses of 6,700 today.
Right. So with what we're expected to administer today, that gets us close to what we have on, I'm doing my math, but that's roughly
correct.
That's the amount that we have, and then we'll get another 6,700 today. Okay.
Correct.
And those, because of the system, the way it's set up, we're giving those out to first responders, healthcare workers who aren't affiliated with hospitals primarily. That's where we are right now.
That's correct.
And it's the responsibility of the State Department of Health to vaccinate in hospitals, correct?
That's also correct.
You can stay off mute because
I'll stay off mute.
I have a couple more. And then the CVS and Walgreens are responsible for our nursing homes and long-term care facilities.
That's correct. And congregate living spaces. That's correct.
And do we have updates on how that progress is moving for those other two? So I just want to be clear to the public, and I always say the millions watching at home, everyone makes fun of me, that we are not responsible for vaccinating in nursing homes, in hospital employees and staff. We are doing first responders, a very important group, and healthcare workers that are not affiliated. And of that, as of today, we've given out all the doses we have, and we're getting 6,700 more. We've requested double that. Is that all correct, what I just said?
That is all correct, Councilmember Jawando. We have no control over the administration of the partnership that the Maryland Department of Health has with CVS and Walgreens pharmacies to vaccinate those assisted living facilities, those congregate living spaces, those rest and rehabilitation centers, nor the hospitals. They maintain their own Pfizer doses. 100% of our doses are the Moderna vaccine, and they in turn manage that and distribute it and maintain the allocation, the scheduling, the appointment, and therein.
Okay, so that was a state decision that was made to move forward in both which type of vaccine was available to us and which they used in those other settings. And
yes, that's correct.
Do we get a report from the state about how the progress is going in the nursing homes and in the hospitals? Do we have that information?
Yes, we do. Yes, we do. The health officers get a weekly summary report, which is some of the data that I used to inform the presentation this morning to council. And so it has the allocations and how many doses they received on a weekly basis, similar to the local levels. We have teased out our county level specific data to speak towards that, but we have the information, and we've actually been working with principally the hospitals to say, if you aren't using your doses, we still have individuals who we would like to vaccinate, and we are working on that partnership and continue to work on that partnership, but we have no control on their doses versus our doses.
That was going to be my next question is if they are, depending on where their capacity is and what they have left over, are we able to work with them? It sounds like you're trying to do that.
We're trying to do that.
No formal state guidance on that?
There's no formal state guidance on that. It's a realistic assessment based on our prioritization, our targeting strategies, and our vaccination plan.
Well, to Vice President and Chair Albornoz, and I think that's yet another thing I think in our communication as a council, as we consider, and as a county, to support that effort. That makes a lot of sense, but we want to make sure that, because when we hear from folks, they want to know, when am I getting it? But they also want to know, well, what's happening? And I think the way you all have presented this is helpful in that this is our responsibility. This is what the state is doing. And here are the total numbers and how fast we can move based on what we're getting. So I appreciate that. And last question I have, because so many of them have already been asked. So the distributions to us are every Tuesday, roughly, or is that correct?
Every Tuesday.
Okay.
Roughly around Tuesday morning. Some last week we got our allotment late after hours Monday evening.
Okay. And to, one of the things, my last question in the national conversation here is everyone's dealing with how do we get the shots in the arms quickly enough, and how do we have the capacity to do so within our public health and our health system and general infrastructure. You've said the numbers that we have that we could vaccinate if we got the numbers that we had requested, up in the 12,000s. Is there, if something changed tomorrow, like a new administration or a new way we get vaccines, which is going to come, do we have the ability to ramp up even past what our current capacity is? And do you see the need for that? So past the numbers that you said, if we even got what we requested to get things out quicker, if we wanted to speed up and we had the doses and we could get them from the federal through the state process, would we need additional capacity to get shots in arms to do that?
So the short answer is yes, we have the capacity. We're working with our partner agencies. Dr. Stoddard, as I indicated earlier, have had initial conversation about using his agency, folks who currently aren't responding to the testing front, but to move over and support the vaccine effort. And so in those regards, we're working with our partner agencies to handle a ramp. We have clinic scheduled. We can also move over our fire and rescue. I have a conversation with Chief Bailey scheduled for tomorrow to talk about increasing that capacity. That will include Dr. Stoddard and Crowell as well. So we have the capacity. We need the vaccines.
Okay.
So, Councilmember, I would add one thing to that, and that is that we're talking to hospitals about how they might help to do this. I think we mentioned earlier, Kaiser and other providers, as well as once we're done with Public Health Administration, how the public health system, how our fire and rescue folks might continue to work to vaccinate other members of the community or staff. But the question for us is, we don't know what that maximum capacity is. And we will hit the maximum capacity at some point, which is why I'm circling back to this conversation about the private care provider activation, because that is, at a certain point, it needs to be a broader array of folks that are doing this process for us.
Okay. Dr. Stoddard, were you trying to say something on that?
Along the same lines as what Raymond has just said. There is right now, while the vaccine totals are low, there's actually an efficiency gained by doing it all through our public clinics. Once we reach a certain point, which we're not going to know until we get a little closer to it, the efficiency falls off by doing it only through large clinics, and you really need to get into the hands of the private providers. And so we're trying to make some assumptions about where that range might be. And I think, we've got testing as a monologue, or at least a comparable we're doing about 30% of testing right now. I think that's probably, once capacity is at its peak for vaccination, that's probably the range, so somewhat more like the range of what we should be doing as a county versus what the private providers should be doing. But I think that's we're not anywhere close to that peak vaccination distribution. And so right now we're just in ramp up phase, and we're ready to take on a whole lot more burden. I think one big thing to understand too is not just could there be a change in federal policy. I think the big thing to realize is about 60% of the vaccines that the state of Maryland has received have gone to the hospital systems for their employees.
60?
At a 60%, 57%. There have been about 350,000 doses right now received by the state of Maryland, and roughly 200,000 have gone to the hospital setting. That's about 57%. The hospitals will finish up their second round of vaccine administration over the next couple of weeks. And so those doses that are coming in, which are largely the Pfizer vaccine, are going to get shifted over to somewhere else. And one might presume that could be the local health. So we may see an increase in volume to the local level, not just because of a federal administration action, just because we're able to finish up one category within the state and now shift that over. Now, whether that gets shifted over to the local health departments, we don't know. Does that get shifted over to, do the hospitals start giving it out publicly? We don't know that either. Do the hospitals, do we get it? Does that go into the private care network? We don't know. We see this huge chunk of vaccine going to the hospitals, and we know that they're going to wrap up whomever's going to take it pretty soon, and that's going to get shifted somewhere else. We just don't know where that's going to be.
Right. Those are all.
I want to register one thing on the back end of Earl's comment, and that is the difference between testing, we're doing about 30% of the testing. Testing is a self-collection process. And so that we've ramped it up and continue to ramp it up depending on the numbers of bodies available. Vaccination is a clinical dependent process, and it requires folks who are licensed and certified to provide those injections. And so I think that 30% is an estimate that we should
might be high considering what's required.
Yeah, it might be high.
Well, I think all of us are interested in, as we a lot of questions there that state has to be directive on and be involved in, but to the extent that we can help. Once you have, I think we should have a view, to Councilmember Rice's point, like on school, we should have a view. We should be asking the questions, and we should do so collectively so that we can, help get those answers from the state. The final thing, the disparities, we still see these stark disparities in the case rates and the death rates, African Americans, Latinos, African Americans with 30%, 6% of the deaths. It's just staggering. Are we seeing, I'm glad we're testing more people, but are we seeing any disparities in our public safety and who we've given these 12,000 vaccines? Are we tracking race and ethnicity, and are we seeing who's reporting? I know they're all required to, but are we seeing any lag in that area, and are we paying attention to that?
Councilmember Jawanda, that's yet another great question. And yes, we are paying attention to that those data are tracked in the COVID summary, and we're looking at that. As part of that tracking and follow-up, we've scheduled a meeting with our Chief Equity Officer, Ms. Tiffany Ward, and our Minority Health Initiative partnerships to look at providing more access to vaccines and how that is impacting the county. So we are seeing that. We are tracking it now prior to any of the other jurisdictions bringing it up for discussion. We started having discussions prior to the holiday, looking at access points and how we could access more and get more vaccines in those communities. There's still disparities in there regarding those providers and those healthcare professionals and fire and rescue who may have received the vaccine versus other populations that are equally in need to be vaccinated. So we are tracking that. We see the data. We're using the data to inform our decision as far as our vaccine staging.
Okay. Well, please keep us posted on that. As we get to wider distribution, obviously there's a huge communications component, but I think we can start off on the right track by making sure our public safety workers, there's no disparities within getting it to our folks. All right. Thank you, Mr. President. Thank you for your work.
Thank you. Councilmember Navarro.
Thank you, Mr. President. Thank you to the team. I am not confused that this is yet one more of those types of situations where we are left on our own devices, really, on a local level, trying to interpret what is the best way to deploy something so important to our community, because the federal government, and more particularly the leadership at the White House, has left local jurisdictions to fend for their own. So I really do appreciate your extraordinary effort to try to put forth a response despite all of these challenges that we have faced ever since this became a reality for us in March of last year. I wanted to emphasize a few things. A lot of the questions I had were also answered. I think it is going to be so critical, and Vice President Albornoz mentioned this, for us to put forth some kind of request and or hold a press conference similar to what we were all able to support, to ask the governor to please provide some more assistance to our residents. This particular issue of the vaccine is the best possible way for us to move forward, not just to save lives, but also to get our economy back on track and get people back on track. So this is very much connected, and we should see it from that perspective as well. So I hope that, through the leadership of the council as well as the executive, that we can all come together and make sure that we are able to put forth these discrete asks that will make this a little bit more manageable. The issue of the provision of vaccines to our disability providers and group homes, et cetera, it's a real challenge. I know that many of us have heard from different organizations. I know CSAC, who has apparently the highest number of seniors in these types of settings, has yet to receive any vaccinations. And so whatever we can do, again, to communicate with our federal representatives, but also whatever we can do locally to figure out how to provide some support would be important. I mean, we know how vulnerable this population is, and it's just frustrating that they're sort of on a parallel track and nothing much has happened there. So I just want to add that as another area where I think we need to provide some advocacy. And then curious about also, we've also received some questions from, for example, our licensed childcare providers, et cetera. And, we responded, of course, but also want to make sure that we are constantly figuring out how to provide those answers quickly and advocate. On the issue of being proactive, as we've mentioned, there will be a change in administration at the national level. I mean, there are some things hopefully coming down the pike. Have we also explored school nurses, not knowing when school is going to be back on track? Are there, have we explored that? Part of my specific question. And also, will we be able to receive some kind of briefing soon on what might be some of those technology enhancements that may be necessary? And then also, again, in terms of who can administer the vaccine, hopefully we get the private providers, but if we also have to take up some of this responsibility, are there some other resources like the school nurses, and also in terms of communication to those who may not have access to technology? How about the health promoters, et cetera, that type of capacity? Is there sort of a time where we might be able to receive a briefing on how we are preparing for the moment where we get a lot more doses and how to then administer those?
So, Councilwoman Navarro, I'll start, and Dr. Bridges can jump in on this at any point along the way. On the school nurses, important to remember that school health nurses are HHS employees, and so they work in public health, and so they have been deployed as part of this overall testing and now vaccination process, and will continue to be so. As we think about moving back to schools, we will look and see how to deploy our health staff so that they can continue to be part of that process, and they will continue to be part of that process. The other piece of this is that we will be continuously updating and briefing you all on progress around technological enhancements and other strategies for getting folks registered or signed up and registered and vaccinated. And I think the other piece of this, one piece of this, I'm glad you mentioned it, is that as we go forward, we are very mindful that there will be folks who will need some assistance and some help to deal with the technology, to sign up in our system, and then beyond that to sign up in the prep mod system for vaccination when it is their turn. So we are looking at ways to engage navigators and other kinds of folks that have that capacity. So yes, that is very much in our thinking. I'm meeting with the Minority Health Initiatives this afternoon. We are meeting with Minority Health Initiatives this afternoon to have some of that conversation. And we'll be, to Earl's earlier point, meeting with HIF and Primary Care Coalition and other folks to identify how we might do that. This will not be an HHS alone or government alone process. This will be all hands on deck.
Absolutely. And we stand ready, the GEO committee, obviously, who oversees technology, et cetera. We stand ready to provide any support that you might need in terms of, perhaps resources if we need to do that. Because again, I think that as on one hand, and we will be very soon taking up a lot of our fiscal, issues as we get updates and then we start thinking about this next budget, there is no doubt that in terms of, restarting our economy and addressing our fiscal challenges, the vaccine plays such a pivotal role, and we want to do whatever we can, notwithstanding the limitations, to be ready to get that going. But again, I again want to reemphasize my gratitude and appreciation, and also want to make sure that our residents here in Montgomery County, that they understand that we know how frustrating this is. We understand how critical this is. We are doing everything we can to put forth the advocacy necessary. And the numbers that you have shared in terms of what we have requested and what we have received, it's a very stark reminder that we are constantly working against the clock to advocate for our county. But again, unfortunately, we are reliant on whatever it is that we receive from the state. That figure of the 80% vaccination, administration, once we receive it, says a lot for the infrastructure that we have been able to put forth. So at this point, again, it's just about us getting those doses, and hopefully our residents see that, that we are ready and that we've been ready and we've been doing whatever possible we can, and we're going to continue to advocate fiercely to receive the appropriate amount that we deserve. Thank you so much.
Just one additional point on something you raised, Council Member. We actually met with the early child care community last night. I think Ms. Cindy Edwards from Public Health, myself, Dr. Bridges joined us a little bit late right as we're wrapping up. We took questions for about a little over an hour. And the nice thing is the session was recorded and will be shared out through the provider network as well. So just
wonderful.
to add on to it. So
wonderful. Please make sure to
do those
send us.
Yes.
That's wonderful. Please send us that link also, and we'll be happy to share that as well.
Sure.
Thank you.
Thank you. Councilmember Katz.
Thank you very much, Council President, and thank you all for all of your questions. Coming late to asking my questions, so many have, and so many answers have been given. In fact, some probably even more than once. But I did want to point out and thank very clearly on the website that we now have that the public is seeing. It truly is a great step up from what we had. I do think that if I could make any suggestions for it, would be that there should be a statement on there how someone could sign up to receive the vaccine when it's their time to receive it. Right now, it's not as clear when you tell us the priorities and all of that, which is terrific, but you don't say when it is your time, this is what you will be needing to do. And if we don't have the answers for that, then I think we should say at this time, it's not clear on what we're doing or how we would do it, but at least someone would have that answer as well. I do think, and I thank you for, and I guess it was Raymond or Earl earlier on mentioned that you're looking at how you will administer the vaccine in Leisure World and in Asbury and in villages of Rockville and the senior resident areas. I think that's very necessary. And I think that if there's a possibility, you could put that on the website and say, this is what we're looking for. And quite candidly, I know that Vice President Albarn started off with this, and I associate myself with everything he said as well as my other colleagues. But I really believe there should be a statement on the website that says the reason we don't know this answer is because we have not gotten this answer from the state. And hopefully the state will be looking at that so that they can say, oh yeah, here's the answer for that one. But I think we're looking at, and others have said it, and I just want to reiterate it, that we are seeing a great level of frustration because the district has been able to go forward because they're more of a state-like than Montgomery County. The Virginia has been so much more, has gotten so much notoriety for moving forward faster than we are. And I think people think we're not doing our job, and that's far from correct. But I believe we have to say time and time again, and you've said it a couple times today, time and time again, this is what we're doing, and this is how we need to be doing it. Thank you.
Thank you. Councilmember Friedson.
Thank you, Council President. Thank you to colleagues for what has been a really informative conversation. I echo a lot of the comments that have been made already. I'll try not to repeat questions, but have a few follow-up questions and comments that I just wanted to make. The first is to thank the public health team. I think there's no doubt that There is a tremendous amount of work that is occurring, and the main issues that is frustrating most residents has nothing to do with the work that our folks are doing. I just want to make that clear. It's been said before, but I did want to say it again. I think we're all very grateful for that effort. I also wanted to acknowledge Council Vice President Albernaz's comments and subsequent comments that have been made with the significant frustration about the information and the rollout and the deployment of vaccines from the state. We have a federal problem and we have a state problem in terms of getting the vaccines that we need to address the crisis that we're in. And it is a significant problem. It's deeply frustrating and it needs to improve. And hopefully the additional numbers that now we're expecting to receive as of the news this morning will change what the state does, and hopefully the county will receive that information that we can share with residents and the actual vaccines that we need to get shots into arms a lot faster than we are, because we are way behind. Did have a few follow-ups. The capacity that I heard earlier and that we've talked about before is 25 to 3,500 vaccinations a day would be the county's capacity, 17 to 24,000 a week. Is that right?
That's correct, Councilmember Friesen, based on our projections. But keep in mind that with those targets, there are some individuals who don't follow up with their appointments. And so we are opening up those appointments as we go, but that is the target as we speak.
Okay. How long would it take to ramp up to that capacity? Is that hours? Is that days? Is that weeks? If that's the maximum capacity, if the state tomorrow said we will give you 24,000 vaccines on Friday, would we be able to meet that, or would we need time to deploy them? I mean, what does capacity really mean here?
So for me, capacity is the ability to get the vaccines out the door. We have the capacity with our fire and rescue and through our testing venues now in those spaces. We've also, as Dr. Kral and Dr. Starr had indicated before, that within that capacity ramp, we have staff and identified staff. We've diverted our school health nursing staff, as Councilmember Navarro mentioned before. We've pulled back some of those capacities from our shelter spaces and from our detention center to be able to handle the ramp up. We've also have Athena brokers, putting in a request for additional Athena brokers. We've also increased our capacity to get clinical support from our Maryland Response Corps. The pros to that is that those clinicians are vetted through the state, and any liability issues are vetted through that. We've also put in a request. The state has asked for our capacity and assistance if we need it, or as we ramp up, to your question, with support from the National Guard. And so we put in a request for National Guard support operationally and logistically, and if they had any available clinical support to add to our cadre of staff. So operationally, that's where we are as far as building up to the ramp, and additional support is forthcoming based on our negotiations and discussions, as we mentioned before, with Kaiser, looking at the hospitals and FDA. So in many of those ancillary partnerships, such as the Federal Drug Administration and Kaiser, we would have to provide the doses to those entities and then establish an appointment system where we would have individuals go to them as a clinical point of distribution or a site. So that's pretty much where we are today.
I appreciate all of that. I think the confusion that I have, and I think some residents have, is we heard earlier, we can only control what we can control. And that is part of the biggest frustration with this whole process. But several of the things that you just talked about in terms of what our capacity is are not things that we control. We don't control the National Guard. We don't even really control outside partners until we have an agreement in place and they're ready. We can flip a switch and hand them vaccines and they can deploy them. That's out of our control at this point as well. So what's the capacity today? And how long would it take to ramp up the capacity that the county controls, excluding things that we have to rely on the state for, things that we have to rely on outside parties that we don't have existing current agreements with, based on agreements we have in place today, staff that we have in place today, and capacity that we have in place today, how many vaccines can we administer?
So the current capacity that we have in place today is between 2,500 to 3,500, including the support that we currently have available with fire and rescue. That's our current capacity today.
So that's the baseline, and then
Correct.
anything above that would require the National Guard, Kaiser, or some of these other partnerships, and we could significantly ramp up from there.
That's correct.
Okay, I just wanted to make sure I understood what we were talking about. So today, if we received 20,000 vaccines from the state, we would be able to come close to distributing those in a week.
Well, I think the key thing here is that, again, some of the ramp up too, like so let's say the state changes their mind, they're giving us 25,000 doses tomorrow. We wouldn't have enough appointments already scheduled for tomorrow to give out 3,500 doses. And so it's all, and like what we generally found is, like, as you could see in our vaccination totals from last week, Wednesday is one number, Thursday is a bit more, Friday is a bit more. That's not because we had the same number of available signups that day, but people need a little notice to say, not everyone's going to be able to say, I'm dropping my practice tomorrow, and I'm going over to the clinic. And so some of ramp up is not just the county being able to be there with a vaccine, it's getting people scheduled, making people aware, having them sign up, having them drop what they were doing to come in and get vaccinated.
Again, I totally agree with that, but you only can control what you can control, and we can only provide information to residents as fast as we have it. What we can control is how prepared we are the second we get the information and the second we get the vaccines in our hand. What we can't control is how quickly people sign up, adopt. What we can't control is how quickly that happens.
Councilmember Frizzy, before you go on to that, let me just say this to you about this: it's when we get those doses and when we can do a schedule to let people know. One of the things that Earl is pointing out is that we get the doses on Tuesday, the Wednesday schedule goes out so people know that there's doses. It's insufficient time. As the doses go up and we can stably predict enough doses to vaccinate across the week, those numbers of folks who are responding will go up. So the capacity is both dose dependent, number of bodies we have, but also the number of people that will respond.
Totally get it. And I've been very clear and critical that the fact that we don't find out until so late and we don't get them until well into the week is completely inadequate. It needs to be fixed and improved, and we have to do better, and we need more help from the state on that. But right now I just want to focus on what the county can control. The question, and I totally get it, but it is a little bit confusing, I think, for most residents to hear that on the one hand, we have plenty more capacity, all we need is more vaccines. On the other hand, our public health folks are so overworked and understaffed that they need time to take the weekend off. And so, I think we have to be careful about the idea of, give a chance to take a break. If we need more people, we should have more people. And we have talked, for months about bringing more people on, providing help. This is not a criticism, to be very clear about how hardworking our public health team is. I think they have done above and beyond, continue to do above and beyond. But the council has continuously said, what money do you need? What resources do you need? What do we need to do in order to be ready to do this? And the concern that I have is that we wait until we need the more capacity and then we start bringing people on. And the way this works, to me, it's like a relay race. The next person starts running before the first person has handed them the baton. And if we haven't started running, if you wait until that person is there, you have to delay to do the handoff.
Councilmember, I would say that it is obvious from the fact that we've produced numbers in advance, that we've matched every dose, we've gotten doses out the door, is evidence of the fact that we're not waiting until we get those doses to do that. We're moving, we were ready when those first doses came out, and we're continuing to plan ahead so that we can continue to ramp up now. So it's not the case that we So we are working.
And I appreciate that. And I think we're doing better than just about, if not every other jurisdiction's.
That's right.
Public health department. I think that should be acknowledged. I have tried to say that as many times as I can. I will say that again here. I do believe, however, that the best way to put pressure on the state isn't for us to talk here at each other about how frustrated we are with the state. I'm doing it too. So I will take full responsibility and accountability for that as well. It's to deploy at our full capacity every single vaccine that we get as quickly as we get it. And I do believe that having no vaccines to give out on Monday and Tuesday would send a very powerful message to residents and to the state that we can take on a lot more than we're getting, and the state better give us more or else our residents are going to be left behind and people's lives will be put at risk. And so I just want to, it's a philosophical disagreement. I totally respect where you're coming from. I respectfully disagree. I think that more than anything we can say here, more than anything we can do, we're not going to change hearts and minds and the state's view by letters, in my view, or by statements and meetings or by emails. We're going to do it by having a system that is sitting there waiting for the state to act. And people will be angry, they'll be frustrated, and they will understand that the county is prepared and the state has not provided the county with what it needs to get the shots in the arms. And so I just take it for what it is. That is my viewpoint. I feel very strongly about that. And I do think that, that we ought to move forward. And if there are more staff members that are needed because the public health team is overworked and understaffed, then we should hire them yesterday. And we should bring more people in. We should redeploy people. If we need to take first responders and move them into those roles, let's do it. Let's bring on volunteers. Let's do whatever we need to do. Let's have a call for action. I have public health people in the private sector who have reached out and asked to provide help. I think we could do more if we had a more concerted effort for that. I think there's more that can be done on this. I know we're waiting for the state, but we can't wait. We have to just, everything that we have, full on 24/7 operation. And if the state can't keep up, the state can't keep up, and we continue to put pressure until they can. In terms of the public safety issues with the 3,000 appointments and having a challenge with adoption, what's the plan for that? I mean, these are folks who are both putting themselves, each other, and the public at risk because they're public facing. Can we require it? Can we move them into positions that are less risky to public health if they haven't been vaccinated? Is there a plan if we have half of our public safety officers and first responders who are concerned or unwilling to take it? I mean, I don't want to be accusatory here. I understand everybody has the right to do what they have the right to do, but the county has an obligation to protect the public interest and public health. Is there a plan of how to do that besides trying to convince them to do it?
Sure, Councilmember Friesen, thank you for that. And I'll ask Dr. Stoddard to add to briefly talk about the survey and identifying those public safety and first responders. We do have a plan. We're working collaboratively with our fire and rescue to identify those responders who are actually out in the public more. Those we're working with the fire and rescue and Chief Patel to look at those public safety officers at the county and municipal level. And so the first dose that we gave them this week is part of that 3,000 allotment that we're getting. And so we take it very serious in our targeting and getting those public safety officers and fire and rescue vaccinated, focusing on those individuals who are out in the public first, and then their staffs who may interact with the public. So that's the current plan. I know Dr. Stoddard supported some of that and worked with a survey to identify those individuals who needed to be in the first queue within that category to get vaccinated.
Okay.
I would only add, I think we've been working with, we've actually been partnering with a psychologist who works in, she actually works in Howard County, and talking about vaccine hesitancy because it applies to all different categories of people. And what I think, the one thing that we found is that there's not going to be a single methodology that's going to convince people to get vaccinated. It's going to be a multitude of different, bases for why people get vaccinated. But I do think a significant chunk of them just want to see what happens to their colleagues who get vaccinated, who got vaccinated last week, who get vaccinated this week. And when they see that, arms don't fall off and, people are able to continue working and you're going to see more people come on board. And there will be some percentage of people, and I think that's what we're trying to get to, is exactly what percentage of people just refuse under all circumstances to get vaccinated. Now, as far as the requirement goes, I think generally the position has been, and this is not just a Montgomery County position, this has been the one that's been even the incoming Biden administration has adopted, is that while the vaccine is still under an emergency use authorization in EUA, there is not an inclination to require people to take it. Once it goes through the more robust, full process, particularly as it relates to younger people, and there's more testing for, it's allowed for pregnant women, but they wanted to have more testing and all those other things for all the, check all those other boxes, long-term effects, and all those things. It may become required in the future, but I think the general consensus is that there is not a strong inclination in most settings to have it be required at this point. So I think there are ongoing communications or efforts within public safety to try and get more people to sign up and get more people. There's been a significant amount of pressure applied from not just the senior most chiefs, but throughout the organization to get more people vaccinated. I would expect more people will become online. I feel like there's some people who are kind of taking a wait and see perspective on this, which I certainly don't encourage, but we have different people and we have to encourage them through different mechanisms. And I think that we're going to continue to do that, which is why I think it's really important to understand as we move through categories, if you're in 1A and you have some hesitancy, you're not going to lose your opportunity to get vaccinated when we move into 1B. You'll still be allowed to get vaccinated. So we're going to bring people along at the pace that they feel comfortable with. And as I said, we're going to try and give different mechanisms where people feel more comfortable. And so even within our responder community, there may be more people who are more inclined to go to their private providers or other things like that as well. So we're going to keep looking at it. I think we need to know exactly what the number is going to be before we make a determination about how much risk there is. And it's important to understand that many of the, for example, fire rescue may not necessarily be as public facing as our EMTs are. So when they're fighting a fire, it's a little bit different than if they're running EMS calls, for example.
Right. So, and I appreciate that. And if there's a bit of a pure trust theory here, which I think makes sense from a psychological standpoint, then it does raise the reality that we should be moving into next tiers and next phases as quickly as possible, and then kind of catching back up to the slow adopters because they wanted to wait a few weeks to see what the impacts were on their friends, to hear from multiple people of their colleagues and friends of, hey, I got it, I feel good, everything is all good. So,
Councilmember, can I just add that's anticipated. I think that there will be some folks in every tier who will be slow adopters and who will adopt a wait and see. Getting a sense of that in our healthcare provider community is part of the survey. As we think about the campaign around this, we're also assuming that that we will have to do progressive messaging, and part of that messaging will be peers talking to each other about, I took it, and here's why I took it to give people.
And that's the Southwest model, so to speak, where you don't
absolutely. We won't stop.
You just might lose your spot in line. If you decide not to board.
Well, we won't delay. You put your priority spot. You use your priority spot. We won't delay and allow you to not. Right. We won't delay moving on to the next.
You can still.
What's going to happen?
Sorry.
What's going to happen? We have 3,000 appointments through public safety. Those will stay closed to public safety. Next week there'll be a similar line of public safety committee of presumably up to 3,000 spots that fire rescue and police will be coordinating. What will happen is I would expect next week, and I'm going to have a conversation with Dr. Bridgers after today about this. We're going to be adding in people, other categories in tier 3 categories, but I've already talked to fire rescue. They're comfortable bringing in private providers into their clinics too. And so what we'll do is they'll stay open and available to public safety people, but we'll be adding in and allowing others to choose the reservation slots starting next week, I think, for other categories. And so we're not going to have those slots just sit there unutilized. We're going to move into other categories within
because we have to get the 50 to 60,000 in this phase, phase 1A done regardless, right?
Right. As soon as we start to see any delay in the reservation, we move on.
Right.
Correct. Okay. We have about 7,000 with police and fire and rescue. So as Dr. Starter indicated, next week we should be moving past that and able to progressively move to the other categories as well. But you were great to say something, Councilmember Freeze.
If you could, yes, thank you. And if you could keep us updated on that in real time, I think that would be helpful. Through email is fine, but just to keep us updated on how those slots are being allocated. The hospitals, 59% is a really concerning number. That was the number that I saw as of, I believe, yesterday in terms of the allocation that they have been able to deploy. Some hospitals and hospital systems are doing better than others. We get those updates on a daily basis. Do we have any indication? Is that an operational challenge? Is that an adoption issue? I have heard from some in the public health case, there are some nurses and others, just like first responders, that are waiting or or wish to wait. But, those are two different issues. Operationally, the county should step in and see if we can help, or we should allow them to help each other, or, figure out ways that we can work with them in the state to get shots in arms, or the governor should deploy more National Guard, troops to provide the support that's just begun. I think was slow to be adopted. If it's an adoption issue, then those vaccines should move somewhere else. I mean, for the time being, the county should take them, or somebody else should take them, so we can get them into arms as quickly as possible. When folks are ready and comfortable, then they should get more. But do we have any indication of which it is, based on conversations with the hospital system?
Not to my knowledge. The only knowledge that I have is that some staff, similar to fire and rescue and across other populations that we've tested now, are hesitant to receive the vaccine operationally, or from an adoption standpoint. We don't have any control over their vaccines. We've had some conversations with actually doing that, with pulling back or seeing if we could identify folks who fall under any particular category to be able to go to one of our hospitals as a provider and receive a shot. We're working through that now, but right now we don't have the indication. They have their vaccines that were allotted to them by the state, and we have our vaccines, and we continue to manage ours and work with them in discussion that if you haven't used your vaccines, we want the vaccines. We would like to use the vaccines, and we have the individuals to get vaccinated. So those are discussions that I've been party to the last couple of weeks.
Well, if there's any updates on that, please keep us informed. I think both of those issues are solvable, but they're solvable in different ways. So I think it'd be helpful to be aware. Just to switch gears.
Can I make one comment? The one challenge in the hospital setting is they're largely the Pfizer vaccine, which it requires the -80 refrigerators. We've been instructed at the local level not to purchase those refrigerators because they're being basically, the state is controlling those refrigerators. The National Guard deployments are including those refrigeration capabilities. The hospitals have them for other reasons. And so we're very curious about what's going to happen with this hospital shipment, because this is an area where we've been told not to prepare at a local level to receive these, at least in the way of having purchased other refrigeration equipment, and it would come with it presumably. But this is an area where we would need more information to know exactly, it would be very difficult to just take what the hospitals have and fully integrate it into what we do without us knowing exactly the process where we get the refrigeration capability.
Right, but there may be an opportunity to bring our folks to them as opposed to, bring the vaccine.
So, Councilmember, that when we're talking about expanding capacity, right now we're talking about how we might use our doses with hospitals, but that reverse could also be true. That is, they shift their focus, and as they're done internally, they may be able to become local providers for large scale vaccination as we go forward.
Right, but it would be helpful to know if it's the operational issues that are part of the problem, because that would have to be worked out before we relied on them to our capacity. Quick 1A question. Those folks you mentioned, they might be added to the 3,000 slots that are for first responders, those people in public health who have not yet gotten or not in public health, in health, that have not gotten it, frontline health workers. How will they learn it? Are they getting information and updates on what the timing is? We've heard a lot from folks who have wondered how they'll hear. They've signed up, they filled out the survey, they've heard nothing from the county or the health department. So what can we tell them?
So if they receive an email to get an appointment for a vaccine and they're put on a waiting list, they will receive a follow-up email notification for times and locations where those doses are available. So if fire and rescue, if there are individuals in the queue to get vaccinated and fire and rescue has some available slots, those individuals who may have signed up for a White Oak Recreation Center, for example, will receive notification via email to go over to fire and rescue at their public safety training academy to receive their vaccine.
So no matter what, they should have either received an appointment or to be on the wait list. If they are neither, they should contact the health department and make sure that they're one of those two things? Just to be clear.
They can contact the health department, or they could go to the website and sign up to receive a notification.
Yeah, they should be filling out the survey. If they're in category 1A, tier 3, they should definitely be filling out the survey so that we're aware of them.
Some people have said that they filled out the survey, they haven't heard anything. So I think that might be an issue.
Right. So if they're in tier 3, if you look at the website right now, we list right now, the only people in tier 3 that we're covering are the public safety folks right now, which is detention center staff, law enforcement, fire rescue, 911 dispatchers. As soon as we open that up to other categories, you're going to start to see dentists, pharmacists, behavioral health workers, lab workers, morticians. They're all going to start receiving emails saying, sign up at these locations. That will be imminent. I mean, as in potentially later this week, certainly early next week, we'll be into.
I would recommend an email going out today explaining to everybody who's filled out the survey, who's in tier 3, to explain what the process is going to be. You don't have to say you're going to get an appointment for Tuesday at 3 o'clock, but it should say, we're getting this, we're getting 6,700 this week. Here's how the process is going to work. First, it's going to first responders because they're in, tier 2. If you haven't received something by date certain, here's who you contact to find out if there was an issue. I think expectation setting, as we hear a lot from public health these days, is really important, and I think that would go a long way. I think the issue is people who've signed up, they haven't heard anything, and they think there's a problem, and that creates a lot of uncertainty. Information here really is power, so I would just suggest that, and you can only give what you can give and provide what you can provide, but you do have information now how you expect it to work, and I think that should be shared imminently, and then like immediately, and then what was imminent. Okay, sorry. Last question. Dentists and other healthcare providers, I think the governor has allowed them to administer the vaccine. I just wanted to confirm that and see if we are thinking about considering deploying other professionals beyond public health workers and hospitals to do that, and if those conversations have begun, because many organizations have reached out to all of us to say, we're here, we're ready to help, we want to volunteer, you don't need to pay us, just we want to solve this public health crisis, what can we do? And so the question is, what are we doing to help them help us?
Oh, Councilmember Friedson, the last indication that I received from conversations with Dr. Gales is that the Maryland Department of Health was considering other vaccinations in the form of dentists. They were also considering veterinarians who typically give shots, intramuscular shots. And so that's pretty much the breadth that I have right now, but they are considering other clinical individuals who could vaccinate. And so once we get that information, I can forward it to council so you can get a scope of all of those vaccinators based on their clinical practice.
Please do. And I think we need all hands on deck here, obviously, particularly as you talk about overworked and understaffed public health agency. We've got a lot of folks in our community who desperately want to be part of this, who desperately want to help us get through it, and we ought to put them to work and allow them to help us get through it. And just the last thing on the website, everything that we heard today, the 12,900 doses received to date, the number that are going to go out tomorrow when we expect the full deployment to be completed, and the numbers that we expect today, and the amount that we expect to receive or have heard to receive from the state. I think the deployment and administration of the vaccines and the percentage as a daily running count, I've asked for that before, I think would really go a long way, both showing how well the county is doing in comparison to others, but also to provide the type of transparency and accountability that residents expect. More of a comment than a statement. Several of us have asked for that. I know, Dr. Stoddard, you've been working on that, so I just wanted to note that again and share Councilmember Katz's points that we asked for the website with all the information, and I think you've done a nice job of delivering it. I think there's some tweaks and improvements, some of which you heard earlier. I would just add that to the list that's been stated, and let you go, Dr. Stoddard, and I will mute myself and yield back. Thank you.
The graphics will be ready. I mean, I've seen mock-ups. There's just cleanups a little bit. I do think there's a question around the timing of it, and I think that for example, when we show the graphic tomorrow, if we show the graphic tomorrow, let's say we did, the percentage would be substantially lower because we're going to get 6,700 doses delivered today that are incorporated in that total, and so there is it's sort of in furtherance of the question, I think, which is what we're trying to determine is, we want to be open and honest, but at the same time, people begin to say, well, you haven't distributed what you have. Well, we've gotten it less than 12 hours since and so it's sort of like a graphic can be very valuable, but it's sort of like there's a lot of context in some of these numbers that I think are really important. And so we're trying to navigate exactly how we demonstrate that context to say, like, it is the better graphic saying percentage of doses that we distribute that we received last week, because that number is consistently high. But is it, you know, if it's real time, then you have dips. Every time you get a new load, you get dips. And it's sort
I'm
of
muted
like,
and then I unmuted. I'm happy to provide suggestions. I'm sure other council
Yeah.
members are
Okay, let's
offline.
look at it. Yeah.
But I think we have the smartest residents anywhere in the world. And I think that our folks are able to understand context. And I don't think that the graphic matters as much as the information. And on this particular case, it's just numbers. And I think people can understand, you know, if you clearly say we received 6,700 today, that 6,700, 100% are not going to be administered that day, and you provide that information. But we can talk offline and further discuss. Thank you to you and colleagues and Mr. President. Thanks.
Thank you, Councilmember Reamer.
Thank you so much. Very helpful discussion today. So much has come forward, a lot of good information. I'll reiterate my earlier comment that the efforts of our public health team, it's been a really long year, and it's been heroic, and we're nowhere near the end. So we've got a long ways to go here. I want to thank Councilmember Albornoz for his opening comments. He made a lot of points that I thought were particularly important. I want to emphasize this issue of a pre-registration system. Dr. Kroll had mentioned that. I think that would help a lot. At the moment, it's just, people are wondering why they can't sign up or at least, get that kind of information. And I think if people could sign into a pre-registration system, then you would have a easier way to communicate with them, and people would feel like the process has started, and it will be clearer that the doses are not available for them to take, and that that's the underlying issue. Having a local dashboard, I think, will be very helpful. I'm glad to hear that that's nearly ready. My general comment here, and I think everyone has made this point, is that Governor Hogan and the entire state health apparatus has to revise our distribution plan. And I have not heard anyone say that the state is not getting the same level of doses as other states are on a per capita basis or some other basis. And yet we are seeing other states, New York, Virginia, DC, that are opening up the process already to older residents, and they want to know why we aren't doing that. And we need a clear explanation from the state for why that is the case. I heard Dr. Stoddard explain that the hospitals have received as much as 50 to 60% of all the doses. And we have seen that the administration of doses by the hospitals has been slow. And we need to figure out how to have an influence there. I think that's kind of a core question. I've been advocating that the federal government needs to stop holding back doses, and it appears that that's where things are moving at the federal level, and that we need to move to more of an age-based administration. It appears that that's where things are moving now at the federal level. Obviously, the question is going to become even more urgent today and tomorrow. Like, when is Maryland going to also move to an age-based, open up the age-based system? And if they indeed stop holding back the second dose, we may see a lot more supply coming in. I'm gratified to hear that the county clinics have capacity to handle at least a significant increase of doses. And so where I wanted to ask a question for our team here, if we have at the moment more staff than we can essentially use in our clinics, is there any discussion about supplementing the CVS strategy, not necessarily with our doses, but with our staff? The lack of transparency about the CVS Walgreens partnership, has really been concerning. Are they staffed adequately to proceed effectively or not? and it just doesn't seem like, I have never seen any of that kind of information. But is there a way that we can partner with our hospitals and with CVS to accelerate their programs while we wait for more doses? And what kind of dialogue do we have with those providers as well? I'll address that to Dr. Bridgers, Dr. Stoddard.
So, Councilmember Rim, I'll start. Currently, with the capacity that we have the right fit for staffing. We've asked Dr. Crowell and others to support and looking at our staffing needs based on the diversion of our school health nursing and others to handle our current capacity. The only thing that I could share with you during this council update is that the conversations that we've had with the hospitals and Walgreens is that we've received notification from the Maryland Department of Health that Walgreens may have additional doses, as Dr. Stoddard indicated, that need to be used based on the shelf life, not a freezer capacity or the lack thereof. They've contacted us once to have 100 individuals to be diverted who are in our scheduling appointment to receive a vaccination. That's the only collaboration we've had with the pharmacies. Again, most of that is managed, if not all is managed by the Maryland Department of Health. And in that regard, we are asked to provide individuals when there's a need. That's the basis that I have during this conversation as far as a partnership or getting staff or supporting the pharmacies and or the hospitals, in addition to what we stated as far as establishing provider partnerships with our hospitals to be able to get folks over to use some of their doses as well.
We don't have any information about how they are staffed up, how that could be boosted, that just purely comes from the federal government through the state.
Yes, and we've actually asked for the pharmacies and their capacities, and I haven't received anything by way of Dr. Gales or from the state that's been sent to us. We have more information about the hospitals in comparison than the pharmacy partnership, outside of knowing that they are targeted and earmarked to support those long-term care facility and congregate living spaces.
Okay, so back to this question of the hospitals have received 50 to 60% of the doses. They're moving slowly. The county could administer more doses based on our capacity. We're not receiving enough doses. How can we influence the state on this issue? How can we move more quickly to stage 1B? What do you think?
But my way in on this is what we said earlier today is that as the hospitals free up their doses, we're to work on a plan for how either they, using Pfizer doses, begin to manage and take on some of the general population or some of our priority populations. But the other one is to figure out how we get the provider community, as I said at the start of the hour, to get our provider community in the public, in the primary care settings, eligible to vaccinate. That's where we're going to get our biggest bang for the buck from. So I think some advocacy on both of those fronts. If you do doses without the providers, we'll be sitting with a surplus of doses more than we can distribute. Both of those things need to come together.
My sense is that the governor, with Virginia and DC moving forward with it, my sense is the governor will be under immense pressure to move forward with getting more doses out to those who are doing 75 and older, which right now is the local health department. So I would be very surprised not to see some kind of announcement this week about some sort of shift. So, which is why I think we're sort of, preparing for, this is, again, we'd like to have more advance warning, but I think it's very plausible that we could be moving fairly quickly into that phase just because of the pressure to move forward. And that's sort of what I alluded to before. I think my concern is, and I think this is where everyone should understand this is a possibility. The first day that we open up 75 and older, it may be in conjunction with other providers. So they may go on to get reservations and there's not a ton of reservations, and there may be like, oh, there aren't that many reservations. Well, that's very possible because you still have a fairly high number of providers who are seeking their vaccinations at the same time that we may be getting at 75 and older. And so I would expect to see, I guess we should begin to communicate more about this collectively, that the first week of 75 and older is in tandem with the tail end of 1A tier 3. And so the doses may not be that high for either group at that point. As the providers finish, it'll ramp up for those 75 and older. So I think I would expect to see some early results and say, oh, there's not a ton of spots for those 75 and older. But that's because of the way the system is set up, where you're starting to roll people in, but you don't have, it's not just 75 and older that we'll be doing at the beginning of that phase.
Okay. Thank you very much for your presentations today. Really appreciate it.
Okay, I think that concludes the questions from council members. I know all my colleagues are really grateful for the work of this whole wonderful team. Thank you so much for all the information you shared today. And we'll move on to Ms. Michelson. Are we ready for an update on the Coronavirus Relief Fund?
Yes, we are. I see that Mr. Madalino is here, and I'll turn it over to him.
Oh, thank you very much, Marlene. Thank you, Council President Hucker. Happy New Year to everybody. Since the last time we've talked, there's been major changes to the Coronavirus Relief Fund because of actions at the congressional level. So just to remind everyone, the CRF deadline to spend or commit the dollars had been December 30th of last year. That's been extended to the end of calendar year 2021. So we have additional time to, in essence, account for the CRF dollars, because we are confident that most of it have been spent. But it does give us some greater flexibility for both how we use those dollars during the year and our reimbursement requests to FEMA. So to go through the information that you have before you, starting first with all of the special appropriations. As you can see, most of the special appropriations have been spent, as we've discussed before, except for the handful that you are well aware of. I would point out that the two biggest items that are yet to have been spent are the rental relief fund. All of that money has been awarded, so it would have qualified for the deadline on December 30th because of the flexibility that the U.S. Treasury Department gave us on how to account for the dollars as being committed, as being spent. So all of the $20 million has been awarded. It just hasn't gone out the door. From our internal accounting purposes, we haven't yet labeled it as encumbered or expended, but it is all awarded. So the only other item, the large items that are unspent, are the broad NDA, and a lot of that is waiting for our internal accounting process to figure out what we get from FEMA, so then what gets booked to CRF and to the CRF, and what is then available for us to reuse. We have submitted $71 million worth of requests to FEMA. As you know, we have not received any update, any formal update on the last two submissions that we put in. So I can't yet tell you what FEMA's response is. We have been going back and forth with answering their questions. And then we have another $40.3 million worth of reimbursements teed up to be submitted before the end of the month. Of course, with the added flexibility to the CRF and the time frame that's been put out into next December, of course, that allows the Biden administration an opportunity to put its own imprint on both the CRF through the directives from the Treasury Department and FEMA for what guidance they're going to provide. As you know, the current administration had been ratcheting down what was eligible for reimbursement. This gives the Biden administration the opportunity to take a look at all of those decisions and hopefully expand what is eligible. So in the money that was passed by Congress in the last relief bill, which I don't know if it has a formal name, so I will just refer to it as CARES Act 2.0. There is money for rental relief. Right now, we believe $31 million will be coming directly to us by the end of the month. We have already submitted all of the paperwork that the federal government asked for to get the money. I know Senator Cardin in his briefing to MACO yesterday also brought up the $31 million for us. So that's the amount of money we expect. There was a substantial amount of money in the CARES 2.0 bill for K-12 education and for childcare. That flows to the state and then will flow to the local jurisdictions. Our assumption is the governor will put that distribution within the state budget when he releases it, potentially as early as Friday, but no later than next Wednesday. So our anticipation is we will know exactly the distribution coming to MCPS for those items when the governor releases his budget bill. That makes complete sense when you think about it, that any of those dollars that came to the state, that it's the perfect timing for the governor to include it in his overall budget submission. So we will be able to get you those numbers when they come out. I would point out that the money for K-12 education was, I think, 4 times more in the bill that was passed in December than in the CARES Act that was passed in the spring. So that is potentially tens of millions, if not closing in on an even higher number for MCPS and federal aid for the remainder of this school year. There is money for transit programs. The money that will support Ride-On will come through WMATA. So just like the initial distribution of CARES Act funding came through the state and through WMATA, we will again have that conversation with our partners. Most of the money will come through WMATA, and Montgomery, Prince George's, Fairfax will all sit down with WMATA, have already started to sit down with WMATA to figure out the distribution for the region for how the transit dollars will support the local transit systems. So we received $31 million in the first go around. We just recently finalized all the agreements, so you will be getting a supplemental shortly to reflect all of the transit dollars that came through the first CARES Act. We will keep you up to date as to what transit dollars we're going to get. And again, I don't think it will be to the same amount of money that we got in the first round, but it will be we are confident it will be in the double digits when the negotiations, when WMATA are over. And of course, as soon as we get the rental dollars in the $31 million I would discuss, we will submit a supplemental. As soon as it comes, we will put the exact dollar amount and put it into a request to you. And with that, Earl, do you have anything you want to add? And now suddenly I don't see Dr. Stoddard. If he had anything he wanted to add about FEMA, we also have various people from OMB with Dave Gottesman here, who's been leading our internal efforts to pull all these numbers together. And we will also be working with MCPS to help them with their FEMA requests, because again, more federal dollars that come in are dollars that provide added flexibility for the whole county enterprise moving forward.
Thank you. Councilmember Friedson.
Thank you, Council President Hucker, and thank you to CEO Madaleno. First off, it's a good update, and there's some positive developments here, and I think that is a good thing. The first is the extension of the CARES Act funding takes a significant amount of pressure off of the county, and as you have noted, was not unique to us necessarily, that there are some challenges with complying with that. But I do want to note that it doesn't add new money in and of itself. It just extends the deadline to allow us to spend that money, and we've made a lot of bets on certain things that haven't changed. And so, it's a positive development to allow the county to be more thoughtful, deliberative, give you and your team in the executive branch a chance to ensure that we are handling this in the most prudent way possible. But it doesn't add new money for new programs. It doesn't provide our ability to continue things that have been committed to. It doesn't do any of that. So I just think it's important that it's good news, but it's not new money in and of itself. The $31 million in renter relief will be significant, and more is needed, but it is a significant boost to the efforts that the county has already undertaken on this. I just wanted to get a sense on that. Do we know how quickly we will be able to deploy that? And how long, when will it start, and how long will it take to get the 31 million out? Do we have any indication of that at this point?
We are hopeful that we will have the money by January 27th. So this will function much like the initial CARES Act. The money will be wired directly to us, since we are one of the designated eligible jurisdictions. And as soon as that is ready, we will have, as we're already having the internal conversations about how we structure a supplemental appropriation for all of you as to how to use that money. I don't know if Dr. Kroll, since his image is still on my screen, I don't know if he is still here and listening, but we will certainly have all of the information of the people that applied for our first round of rental relief. So we have a good database moving forward. Hopefully, with a new administration, there won't be the same strings attached to some of the federal dollars, as far as allowing us flexibility to cover the needs of all of our residents. So we will have that plan for you when we have that appropriation.
Got it. So January 27th, we would expect to get the money. The council should subsequently, very shortly thereafter, receive this.
But that is the target we've been told, to expect the money out the door by the feds.
Got it. Okay. And then separate from this pot of funds, so to speak, is the restaurant relief part of the governor's package that he had previously announced. I believe there was 4.9 million in that allocated for Montgomery County restaurants.
Mm-hmm.
What's the status on that? When should the council expect to get a supplemental appropriation, and when will that program start, and will the restaurant?
Thank you for bringing that up. The first tranche of money that we got from the state has all been expended by MCEDC. MCEDC, the Economic Development Corporation, for people who don't know the acronyms that may be listening, is going to take on the responsibility of providing that the next round of restaurant relief. We've worked it out with them, and so I would imagine my expectation is the supplemental appropriation will be with you very soon to allow them to once again be the conduit for putting that money out the door, since they worked with the first round.
Yeah,
and
just so everybody, just so colleagues are clear, that was the 7.8 million. It was 8.2 million. We used 400,000 for to make sure that the 3R program was fully funded. Used the remaining 7.8 million that went to MCEDC to provide $10,000 grants that were the most flexible grants that we had for restaurants. Could go for equipment, could go for losses, could go for a number of different things. So what you're saying, just so everybody is clear, this would go into the same type program. Is the idea that there are more than the number of applicants, so more businesses would be eligible for that same 10,000, or will this be those who have applied who had eligibility higher than 10,000 would be able to do it, or both? Would it be a new application where either could be the case?
Councilmember Friedson, I don't know the answer to that question off the top of my head. We will get you that answer.
Okay, that'd be great. A timing of when we should expect it, and then what the eligibility would be. That would be extremely helpful. Obviously, this is a time when businesses are desperately struggling. We've closed indoor dining. This relief, can't come soon enough. It, could have come sooner. Obviously, we can't control when the state provided the county the money, but as soon as the county has it, we should be getting this money out to these local businesses that desperately need it as quickly as possible. Okay.
And we also, can I give you a brief update to the tourism grant program, which again, on the chart that you have before us is shown as only like 1% expended. We will have all of those grants out this week. So the determination has been made and all of that money will be going out the door.
Your ears must be burning, because I was going to tell you that I have received very positive feedback from how the tourism grants were administered, the information that was provided, the speed at which that was turned around. Some of the grants have been slow and administrative challenges. Some have been better. This one was better, and I've been critical when things were not as good as they should be. This was one that was handled well, and so I just wanted to thank and acknowledge the finance team, Lori Boyer and others who I know worked really hard on that as well.
Well, can I say, Councilmember Navarro repeatedly has encouraged us, implored us to learn from all of these programs and build back stronger for everything that we're doing. And so hopefully all of these, I know this is one of your favorite words, all of the iterations that we've had through this process, we are learning and hopefully improving. You see that through, whether it's through the public health team or all of our assistance programs, we are trying to make sure we do not make the same mistakes that we made before, because there are plenty more mistakes that we can make, but hopefully not the same ones.
We all appreciate that. And I shared Councilmember Navarro's interest, and I think we all do. And anytime we're critical, it's with the best interests of residents in mind, and we all want to be here to help and support and provide what is needed. On reopening grants, do we have an understanding of whether everybody who's applied to the reopening grants have been notified and all the money has been out the door, what the status is on that? If you don't have it, if you could just get that back to us.
Yep.
I've heard some conflicting information from applicants, and obviously it would be helpful for us to be aware of what the status is and whether what we're hearing is a problem that needs to be worked out or whether it's just part of the process that hasn't been fulfilled. Okay, that's all I have on the grants. I just want to thank the council president for what I thought was a really terrific memo on December the 17th, sent over to the executive branch. I understand the executive branch has requested a slight delay from what was requested in that we're supposed to be receiving some of that information on Friday. So I will reserve most of my comments and thoughts on what is needed and what we get once we receive a savings plan and other things. But I did want to acknowledge one of the things in that memo was a plan for differential pay. And I just wanted to get a status on that because we had been told previously that differential pay would not continue after the new year without council approval and without a specific plan for how to pay for it based on the January 1st pay period. So far, $77.7 million has been paid out over 20 pay periods. This Friday, if it continues, that would put us well over $80 million if we stay on the current projection. So I just wanted to get a sense of what is the status of that, whether or not differential pay is continuing into the new year, and what the decision is based on what had been publicly committed to the council and to county residents prior to that.
Right. So you will have, if all proceeds as I am hopeful for, you will have all of those answers by Friday.
Okay. The one answer that we don't have to wait till Friday is differential pay continuing into the new year? Right now, is differential pay still in effect in Montgomery County.
It is for this pay period.
For this pay period, which takes it into
Yes.
calendar year. Okay, so that has changed, and is there something that changed based off of? Because I think previously you had said that you didn't have the authorization to continue it into the new year without council approval.
Because it is one of the catch-22s of the CRF being extended beyond December 30th. So that's why we are hopeful that with what we submit on Friday, you will see something different.
Okay, I don't want to get into too much of a commentary here, but this is the disconnect that I don't quite understand. CRF extending allows for the FEMA strategy, which was a deeply flawed strategy, to not be the deadline that it was previously, because we were told that in July that most of differential pay, 75% of it, was going to be reimbursed. That was what the entire fiscal strategy was based on. The hope that would happen, the overwhelmingly positive response. Hope is not a fiscal strategy. As I said before, it turns out that's not likely to be the case. Some of the concerns that I have raised previously on the timing that we would be likely to hear back from FEMA and how challenging it is to get FEMA reimbursements wasn't based on my experience. It's based on Dr. Stoddard's experience and statements, and everybody who we've talked to who know a lot more about this type of thing than I do. The challenge with the continuation is the authorization wasn't because the CARES Act funding didn't continue, is that there's no more money in the CARES Act funding. That money has all been expended. And so now at a certain point, something's going to have to backfill into the CARES Act bucket. And the concern that I have is we're spending money that we don't have. And at a certain point, when you're spending the CARES Act funding, there could be a discussion and a policy question of whether or not that is the right priority or not the right priority, whether we could afford it or we can't afford it, or what we should be spending the money on. And that's a very fair question to have. But at a certain point, once you spend all the money, there's no argument. Zero is as zero does, and we're beyond zero now. And so I'll just leave it at that. I think these are conversations that we'll have to take up next week at a more robust conversation once we receive what you send over to us. But I have some significant concerns about a strategy that is spending money effectively that we don't have. Thank you, Mr.
So I think I can answer the beauty of the internet while you are speaking. I think I can give you the answer to your reopen question. As of the 6th, 2,304 reopen grants have been approved for a total of $7,394,000. An additional 234 applications are under review or in follow-up, awaiting clarification or information from the applicants.
Thank you.
And I should also note one of the things that I think at our last meeting, when you had the revenue update, one of the concerns we had with our projections moving forward were all of the various income supports that the federal government had provided as part of the CARES Act were due to end at various points at the end of the year. Many of those have been extended, including the enhanced unemployment insurance benefits at $300 a week. And of course, the Biden administration is talking about something additional. There were the $600 checks for people who are eligible, I think for individuals making below $70,000 and households. Those $600 checks will be going out. But importantly in that legislation, it fixed a severe error in the first bill, which left households that had undocumented individuals out from receiving. That not only has been fixed for the $600 checks, they will get the $1,200. Those households that were left out the first go around will get those $1,200 checks that they would have and should have received in the spring. So that will be some additional money flowing into the pockets of our residents, which obviously have an impact on what those residents are able to put right back into the local economy. So there were things that passed in that bill that have support, will help the state and the county that aren't direct monies that come to us. And of course, the Biden administration is already talking about adding money to state and local governments.
Okay, thank you. Councilmember Reamer.
Thank you. Councilmember Friedson really covered the questions that I also wanted to ask, so I thank him again for his incisive focus here. We're going to get a savings plan to summarize here on Friday. There will be a change in the differential pay reflected in that savings plan. And there's an acknowledgement, well, there's not a clear answer that I'm understanding. You know, the previous comment from the executive branch was that there was not authority to provide the differential after the end of the calendar year 2020. It is still in effect. I'm not sure what I think of the news that there'll be some change in the savings plan. We'll see. The fact that we've spent $77 million on this, vastly exceeding what we've funded our small businesses for their relief, or, you know, employees that could have been hired for testing and vaccination programming, all kinds of things we could have done. So we'll see what we see on Friday. I guess that's really all there is to say about that at this point. So, okay, thank you.
Okay, I think there are no other questions.
Mr. President.
Yep.
Mr. President. Yes, I did text you maybe.
I'm sorry, Councilmember Navarro. Oh, there you go. Yep. Councilmember
Yeah,
Navarro.
I was going to wait on this, but since my colleagues have brought it up, number one, we are going to kind of kick off this conversation. I think, as you know, on the consent calendar, we're going to introduce our spending affordability guidelines. This sort of kicks off also a lot of this kind of conversation. There are a lot of pieces that we do need to address because like the last recession, in which I have not so very many fond memories as somebody who was very new to the council, one of the things that was very, very useful was that, you know, the executive and the council leadership very quickly, of course, with our central staff, came together to pretty much lay out everything that is in front of us. The current state of affairs, the projection of the gap that we are trying to address, the different variables that are confronting us, and then we work together to develop scenarios that hopefully we could all roughly embrace. And that was very important. And I have communicated this to, spoken to both Council President Hucker and Councilmember Albornoz, as well as our central staff. And we have had some preliminary conversations with the executive. It is absolutely critical that we do this because the broader set of options that we may have to entertain are going to vary a lot depending on many of the things that are still pending. But there is no doubt that we have some immediate issues to address, and they all range from differential pay to what will we do regarding responding to the needs of our residents, what will we do regarding our reserves, what are we going to do regarding our employees. All of this comes together as a broad package, if you will, of decisions that we're going to have to make in order to position the county in its best possible fiscal position. And so I wanted to chime in as chair of GO, because while I think that, up until now, rightly so, we have focused on some of these discrete issues, we're now entering that phase where we're going to have to begin to think comprehensively about the next budget. I think Councilmember Rice pointed out, what are we going to do, for example, with the school systems budget? There are a lot of moving pieces, but the most important thing is that if we are going to make some changes in our fiscal policies, if we are going to take into consideration some of the things that have changed, we need to do it through that lens of, what this will mean, not only right now, but going forward as well. So just wanted to make that commentary, and I know we're going to get really into this very soon. But it is important for all of us to start thinking more comprehensively about what this means writ large for the fiscal health of our county. Thank you.
Having also the flashbacks of the last recession from the role that I played at the state level, I do believe right now that one of the lessons from the last recession across the country is there is an understanding and a belief that federal assistance actually does help the economy and save the economy. And I think there seems to be a desire to do more than what was able to be done in that 2008 to 10 timeframe. So again, going back to your desire for everyone to learn their lessons, maybe at the national level, there was a bit of people learned what relief and stimulus means for keeping the economy going. So.
Absolutely, thank you.
Great, Council Vice President Albornoz.
Thank you. I just want to echo that point. It's so important. And I appreciate the conversation that Chairwoman Navarro and I had the other day on this very issue. Going systemically through line item, program by program is not going to cut it this year. There does need to be a more systemic approach, and doing that in coordination with the executive branch will help manage the community's expectations, will help expedite the process by which we have these very challenging conversations, and avoid unnecessary conflict and anxiety and anxiousness by a number of our key stakeholders. So I'm totally on board, and it's in everyone's best interest that we, as much as possible, be on the same page, acknowledging there's a lot of moving pieces, as you noted, Mr. Madaleno, with the money we may or may not receive from the federal government. But having several scenarios, as Chairwoman Navarro mentioned, is critical. And having been on the inside last time around, I've talked about this many times, it would have been very helpful and was very helpful, when we had that systemic approach. So thanks.
And we're also very fortunate that with Councilmember Rice being the Mako point person on education, that there are some very important decisions that will be made by the governor and the General Assembly that will inform what we do with funding for MCPS. And I'm sure we will all benefit from both his guidance and his willingness to get involved in Annapolis. However, involvement in Annapolis will take shape this year.
Exactly. We're all counting on Councilmember Rice to fix this. Okay, let's
by
move
Friday.
On further into the consent calendar. I need a motion to approve the consent calendar.
So moved.
Councilmember Rice moves. Councilmember Katz seconds. I don't see any other comments from my colleagues. All those in favor of the consent calendar, please raise your hands. Terrific. That is unanimous. Okay, with that, we can now recess until 1:30 for public hearings. Thank you, colleagues.
Folks, that once the coronavirus vaccine is out there, expect a lot of scams to come as people are paying to get further up in line, which will never really be a thing.
Wow, that's